Hello my dear doctors, welcome back. This is Dr. Azam here, your faculty of anatomy at PrepLadder. And now we are going to discuss the questions that has been asked in the FMGE Pulse Test. So let us discuss all the questions of anatomy that has been asked in your FMGE Pulse Test one by one. So let's get started with the question number 1. After the parotid ectomy operation, a patient presents with excessive sweating and redness over the parotid region. What is the diagnosis? The moment you read the question, it explains us about the Frey syndrome. Now let me tell you the concept regarding this one. In Frey syndrome, what is going to happen? Ultimately, auriculotemporal nerve is the one which will be supplying to the parotid gland. So we have already learned in our regular classes, in our videos, we have already learned that auriculotemporal nerve finally will be supplying to your parotid gland. Now, in the Frey syndrome, what happens here? The auriculotemporal nerve is getting injured. Now, once the auriculotemporal nerve is getting injured, now it is trying to regenerate. Now, regenerating auriculotemporal nerve most commonly joins with the great auricular nerve over here. And we know very well that the great auricular nerve is the one which will be supplying to the skin over the angle of the mandible as well as the lobule of the ear here. That is the nerve, that is your great auricular nerve which will be supplying in this region. Now what happens here, when the person is trying to eat something after the parotidectomy operation, when the person is trying to eat something, what is going to happen? Auriculotemporal nerve will be stimulated. But this time, instead of stimulating the parotid gland for salivation, it is going to stimulate the great auricular nerve. And that is the reason why in this region, the parotid region, it will be redness and sweating. So therefore, on eating, if there is a redness and sweating in this parotid region, that is nothing but your Frey syndrome. So therefore, this question explains about the Frey syndrome over here. Now moving on to the next question here. Identify the defect in the given image. Now in this image, what is the defect which is given here? Option A, open neural tube defect. See, it cannot be this answer here. Why? Because in open neural tube defect, this is a general term which is used for like anencephaly and spina bifida. We know very well in the neural tube there will be cranial neuropore and the caudal neuropore. Normally these neuropores has to be closed. The cranial neuropore will be closing on 25th day and the caudal neuropore will be closing by like 27th or 28th day. It has to be closed in normal people like you and me. Suppose if it is not closing, then failure of closure of the cranial neuropore that will lead to anencephaly and failure of closure of the caudal neuropore that will lead to spina bifida. So it is actually a general term which is used for anencephaly, spina bifida and all. So that cannot be the answer here, looking at the image here. Now, even the spina bifida occulta cannot be the answer here. So these two options are ruled out. Now, out of the option B and D, that is meningoencephalocele and encephalocele, the more appropriate answer here will be the encephalocele. Why? Because you can clearly see that there is a sac which is protruding out in the occipital region over there. And in that, you'll be able to appreciate that, the nervous tissues will also, protrude outside. That is why the term that will be used here is encephalocele. So the correct answer here will be option D. Now, moving on to the next question here. What is the type of the cartilage present in the histology section, which is given below? Now, in our regular classes, in our regular videos, when I taught you about the different types of cartilages and how to identify them, we know very well that we are having three types of cartilages. One is your hyaline cartilage, another one is elastic cartilage, and the next one will be your fibrous cartilage. Now, these cartilages, there are two important points to remember. First of all, please look at the cells, the chondrocytes. The chondrocytes, whether they are arranged in groups or they are actually arranged in the rows there. Now, in this image, you can clearly see the chondrocytes are actually arranged in the form of groups here. So, we can clearly see the chondrocytes are actually arranged in the form of groups over here. So, when the chondrocytes are arranged in the form of groups, it can be hyaline cartilage or elastic cartilage. It cannot be the fibrous cartilage. Why? Because in fibrous cartilage, chondrocytes will be arranged in the form of rows there. So now, once we have come to a conclusion, once we have narrowed down the answer that it is hyaline or elastic, now please look at the matrix. Now in the matrix, you can clearly see the matrix is completely glass-like, transparent, shiny, glass-like. It is like halos. The word hyaline itself will come from glass-like structure. So therefore, my dear friend, this cartilage here will be the hyaline cartilage. The correct answer is option A. It cannot be elastic cartilage. Why? Because in elastic cartilage, even though the chondrocytes are arranged in groups, But when you see the matrix, you'll be able to find the branch elastic fibers, which are not visible in this given image here. So therefore, the correct answer is hyaline cartilage. Moving on to the next question. Which of the following nerve supplies the muscle that is involved in the movement which is given below? Now, if you look at this image here, in this image, the person is trying to shrug the shoulders. Now, shrugging the shoulders, it is actually done by trapezius muscle over here. And trapezius muscle and sternocleidomastoid muscle, these two muscles are supplied by spinal accessory nerve. That is your 11th cranial nerve, that is spinal accessory nerve. So correct answer is option A, spinal accessory nerve. Even this question was also given in your previous year's FMG exams. So please remember about the spinal accessory nerve. It will be supplying to two muscles. One is sternocleidomastoid, another one is trapezius. And trapezius muscle is the one which will be actually helping in shrugging of shoulder. Suppose if this nerve is gone, then therefore it will lead to dropped shoulder. And that image-based question was actually given in your FMG exam previously. Now moving on to the next question here. Another very high yield topic for your FMG exams, my dear friends. Please revise this topic before going to the exam. Now, which of the following structures develop from the 6th pharyngeal arch artery on the left side? It should be from the 6th pharyngeal arch artery on the left side. Now, option A, arch of aorta. Arch of aorta will be derived from the 4th arch artery, and that too on the left side only. So, left 4th arch artery will actually give rise to your arch of aorta. Ductus arteriosus, which is present between the pulmonary artery and the arch of aorta, it is the one which will be derived from left 6th arch artery. Left 6th arch artery only. Now, carotid arteries like your common carotid artery, external, internal carotid artery, all of them are actually derived from 3rd arch artery. Now, here I'm not writing as right or left. Why? Because on either side, on both the sides, remember 3rd arch artery is the one which will be going to form all the carotid arteries. Subclavian artery, it is actually different on the right side and on the left side. Now, please remember on the left side, the subclavian artery will be actually derived from left 7th cervical intersegmental artery. Left 7th cervical intersegmental artery, it is the one which is going to form the left subclavian artery. Whereas the right subclavian artery, it is derived from 3 sources. It is actually derived from the right 4th arch artery, as well as the right dorsal aorta, as well as the right 7th cervical intersegmental artery. So therefore, the development of the subclavian artery is different on a right and left side. Now, what is asked in our question here? What is derived from the 6th pharyngeal arch artery, that too only on left side? So the correct answer here will be ductus arteriosus. Now, moving on to the next question here. Identify the muscle that is defective in the given image. And you know, this image which is represented here, which is given here, is actually the image of Trendelenburg sign. The person is walking with a lurching gait. And in lurching gait, the muscle that will be involved here will be the gluteus medius and the minimus. So these two muscles are involved here. And apart from that, the nerve which is supplied to them will be the superior gluteal nerve. And please remember one very important point. Let me revise this here itself. It might be helping you in your next exam. So when the person is walking here, you can clearly see the right foot is on the ground and the left foot is off the ground. And in the image, we can clearly see the left side of the pelvis is sagging, or we can say it is dropping. If the left side of the hip is actually dropping, remember the contralateral side, opposite side gluteus medius and minimus muscle is gone, and the contralateral side, I mean to say the right superior gluteal nerve will be involved. Please remember that point because it is like a repeat question in your FMG exams. Fine. Now moving on to the next question here. A 32-year-old patient presents with swelling below the ear and complains of pain in the lobule of the ear. Now, my dear friend, remember, this question is actually given in your FMG Pulse exam just to test your patience in the exam. Don't try to jump to the conclusion the moment you read this one. I have seen like n number of students, the moment they see swelling below the ear and there is a pain in the lobule of the ear, because always they'll be mugging up. In this region, it will be great auricular nerve supplying. Yes, they'll be marking the first option here as great auricular nerve. Please don't do that. Read the entire question first. Okay. The patient also reports difficulty in completely closing the left eye and experiences trouble while eating the food. It means that it is not only about the sensory loss, it is also the motor loss. He is not able to close the left eye. That means there is some problem with orbicularis oculi muscle over here. Apart from that, he is unable to, eat the food properly here. Might be the muscles of face, that is buccinator muscle, is also involved over there. So not only the sensory loss, it is also explaining you the motor loss. So let us rule out the option. It cannot be great auricular nerve. Great auricular nerve, it is sensory. It is supplied to the skin over the angle of the mandible and the lobule of the ear. It cannot be great auricular. Why? Because motor, symptoms are also given over here. Auriculotemporal nerve, it cannot be the auriculotemporal nerve. It is the one which will be supplying to your parotid gland and all, and it will be supplied to the skin over the temporal region, auricular and temporal region, but upper 2/3 of the auricle. Now, the correct answer here has to be the facial nerve. It cannot be the vagus nerve. Why? Because vagus nerve has nothing to do with your muscles of face and facial expressions and all those things. So remember, the correct answer here is facial nerve. Now, how you're going to justify this answer here? Why this swelling below the ear and pain in the lobule of the ear is given here? It is explaining you about there is some pathology related to parotid gland. And we know very well, facial nerve is the one which is going to pass through the parotid gland. So from there, it is trying to explain you there is some pathology of the parotid gland which is compressing the facial nerve. And because the facial nerve is getting compressed, we know very well it is supplied to the muscles of face. And because it is supplied to the muscles of facial expression over here, yes, of course, the person is unable to close the eyelid, as well as there is problem with, eating the food and all. So the correct answer here is facial nerve. So my main intention here to tell you is that don't read the first line over there and jump to the answer as great auricular nerve. Is it okay? Please read the question completely. Now moving ahead with the next question here. Which bone is most likely to be fractured in an injury to the anatomical snuff box? Now this question has been included in your FMGE Pulse Test. Why? Because anatomical snuff box is a very, very important concept when it comes to your FMGE exam. It's like a repeated n number of times in your exams. So please study about the anatomical snuff box completely here. Now in the anatomical snuff box, laterally there will be like two tendons. One will be the abductor pollicis longus, another one will be the extensor pollicis brevis. And medially there will be only one tendon, and that one will be extensor pollicis longus tendon. Fine. Now once you are done with the boundaries in the floor, remember in the floor there will be the styloid process of the radius, and then there will be the trapezium bone here, and then the scaphoid, and then the base of the first metacarpal. Now in the floor you also have scaphoid there, and scaphoid is most commonly fractured carpal bone. Most commonly fractured carpal bone will be scaphoid, and therefore the bone which is most likely fractured in the injury in anatomical snuff box will be the scaphoid. And this has been given as a clinical question also in your FMGE exam. So once the question was something like this: a person falls on an outstretched arm, and when the person falls on an outstretched arm, he comes to the clinic with the pain in anatomical snuff box. So the pain in anatomical snuff box is due to the fracture of which bone? Of course, it is scaphoid, which is in the floor of anatomical snuff box. Perfectly done. Now moving on to the next question here. Identify the labeled structure in the given diagram. Now why I have given you this question here? My dear friends, please be perfect with 3 sections of the brain. Your exam paper is not going to get completed without a section of the brain. So sagittal, the transverse as well as coronal section, please learn the sections of the brain perfectly. You should be able to identify all the structures there. Now in this given diagram, option B here is corpus callosum. Option B here will be the corpus callosum. I think it is given in this one. Option B is corpus callosum here. And then option C here, this is hippocampus. And from the hippocampus begins your fornix. And this fornix will be going and joining with the mammillary body present over here. So this option A here has to be the fornix. So A is fornix, and B is corpus callosum, and C is hippocampus. Option C is the right answer here. In this way, you'll be able to easily identify. Now moving on to the next question here. At the level of facial colliculus, the fibers of which cranial nerves form a loop around the abducens nucleus, creating the colliculus. This itself is the explanation of facial colliculus. Facial colliculus will be actually formed due to which nucleus? It is formed due to 6th nucleus, that is abducens nucleus. But why the name is given as facial then? Why? Because remember, the facial nerve fibers, the facial nerve is the one which is going to loop around the abducens. So this I taught you when we studied about the transverse section of the pons. Now when you take a transverse section of the pons here, imagine this one here to be the abducens nucleus, and then the abducens nerve is coming out here. This is your sixth nerve. Whereas this one here will be the facial nucleus here. And then the facial nerve is actually going to take a turn around this nucleus and come out. And because of this reason, what is going to happen here? There is an elevation formed here, and this elevation will be referred to as facial colliculus. So therefore, facial colliculus is formed due to which nucleus? It is formed due to the sixth nucleus, abducens nucleus. But why the name is given as facial? Why? Because yes, the cranial nerve number 7, the facial nerve is going to take a turn. It is going to form a loop around this abducens nucleus. So the correct answer here will be the facial nerve. Option C is the right answer here. Moving on to the next question now. A 35-year-old male presents with weakness in elbow flexion of the elbow. Fine. And there is a loss of sensation over the lateral aspect of his forearm. Now the first thing here is, if there is a loss of flexion or weakness of the elbow flexion here, it is representing that the muscles in the anterior compartment of the arm, I mean to say biceps muscle, is compromised over here. So if biceps muscle is gone here, yes, the person will not be able to flex the elbow. Okay, number one. And then the second hint here is, there is a loss of sensation on the lateral aspect of the forearm. Now what is the nerve which will be supplying to both of them? Please remember, the correct answer here will be musculocutaneous nerve. We remember from our golden rule that musculocutaneous nerve is the one which will be supplying to all the muscles in anterior compartment of the arm. Not only the anterior compartment of the arm, the muscles over here, after supplying to this muscle, musculocutaneous nerve is not going to stop here. It's going to continue, and it continues as the lateral cutaneous nerve of the forearm. So muscles in the anterior compartment of arm, whereas skin in the lateral side of the forearm. Musculocutaneous, remember like this. Okay. So therefore, which of the following nerve is most likely involved in this patient condition? The correct answer here will be musculocutaneous nerve. Moving on to the next question now. A 35-year-old athlete presents with difficulty climbing the stairs and rising up from the seated position. Now try to understand here. Right now, for example, you and me, we are in the sitting position right now. Now in sitting position, what is happening at the hip joint? Our hip joint is flexed. Now from this flexed position, when you're trying to stand up, from the sitting position, when you're trying to stand up, you're actually extending the hip joint. And extension at the hip joint is done by gluteus maximus muscle. Okay, let us read the question further. Upon examination, there is a weakness in hip extension. Okay, it's already given here. The person is unable to extend the hip. Which muscle is most likely affected and what is the nerve supply? It is gluteus maximus, and we know it is supplied by inferior gluteal nerve. Gluteus maximus, and that is supplied by inferior gluteal nerve. Moving on to the next question now. In a histological image of the thymus, which cell type is not present in the medulla? Thymocytes, epithelial cells, Hassel's corpuscles, and dendritic cells. Please remember, the correct answer here will be the thymocytes. Thymocytes will be mostly present in the cortex part of this one, not in the medulla part of this one. There might be few thymocytes present in the medulla part also, but mainly they are concentrated in the cortex part. And then remaining all the cells like epithelial cells, dendritic cells, and Hassel's corpuscles is actually the feature of this one here. So all these are present in the medulla part of this one here, except the thymocytes. So you can rule out that one because they are mainly concentrated in the cortex part. And by this, my dear friends, we have discussed all the questions that were asked in your FMGE Pulse Test. I hope you got all your answers right, and I hope your concepts are cleared here. All the best for your future exams. Thank you.
Hi guys, let's start the discussion of surgery questions. First, a 45-year-old woman comes to the OPD with history of a lump in the left breast. So first thing, where is the lump? Lump is there in the left breast. Okay. On clinical examination, the size of lump in the left breast, it is 9 into 10 centimeter. It means breast is massively enlarged. Size is 9 into 10 centimeter, and there is no axillary lymphadenopathy. So lymph node is not involved. Breast is massively enlarged. If you see the biopsy report, histopathology of biopsy, yes, here there is increased stromal cellularity and typical leaf-like architecture. So these are the clues. Can you tell me the diagnosis? Breast is massively enlarged, no lymphadenopathy, axillary lymphadenopathy. there is stromal cellularity and leaf-like appearance or leaf-like architecture. And obviously, this is what? Leaf-like phyllodes. So, it is leaf-like phyllodes. Phyllodes tumor, it is also known as cystosarcoma phyllodes. What's the name? This is cysto plus sarcoma plus phyllodes. So, this is cysto plus sarcoma plus phyllodes. It means this tumor behaves like sarcoma. And what is the most common route of spread in sarcoma? In sarcomas, there is hematogenous spread. Lymphatic spread is not seen. That's why there is no lymphadenopathy. Here, there is no lymphadenopathy. So, what's the name, guys? It is Phyllodes tumor. Phyllodes tumor. Cystosarcoma phyllodes. Clear? In giant fibroadenoma, there is no leaf-like architecture. It is not inflammatory carcinoma breast. Why? Because in inflammatory carcinoma breast, approximately 75% patients, they have what? Lymph node metastasis. Approximately 75% patients have lymph node metastasis. And inflammatory breast cancer, it is most malignant type of breast cancer having worse prognosis. Clear? And there will be inflammatory changes in the breast. It is not ductal carcinoma, because here, if ductal carcinoma is there, usually the size is not big and there is lymphadenopathy, there is no leaf-like appearance. So here, what's the correct answer? The correct answer is option A, cystosarcoma phyllodes or phyllodes tumor. Okay? See this question, what is the likely diagnosis for a patient who visited the outpatient department OPD experiencing intense pain during erection and deviated penis for the past half year, right? Now the problem, if there is only pain during erection, this is priapism. But if there is deviation in penis also, what happens? It is Peyronie's disease. See what's the problem here? You can see, this is the penis. And if there is upward curvature, this is the penis, this is the glans penis. Guys, what is the problem here? There is dorsal plaque. There is dorsal plaque. So there is dorsal plaque, fibrous plaque. Because of that, there is upward curvature. And here, this problem is there for the past half year, right? So what is the diagnosis? It is not priapism, because in priapism there is pain during erection. But what? It is Peyronie's disease, because there is painful erection plus penis is deviated. What happens here? In majority of cases, in approximately more than 50% cases, there is spontaneous resolution. So what we do? Nothing, only observation and emotional support. But imagine if patient is not going to resolve, the condition is not going to resolve. In this case, what we do? We go for operation, Nesbitt operation. So straightening of penis is done with the help of non-absorbable sutures. That operation is known as Nesbitt operation. So for this Peyronie's disease, we are going for what? Nesbitt operation. Clear? So what is the correct answer here? Correct answer is option A. Now see the next question. A baby playing unsupervised. Typical history. A baby playing unsupervised brought with complaints of difficulty in swallowing. It means patient is having dysphagia. So whatever problem is there, it is related to esophagus, right? So there is dysphagia for the last 5 hours. X-ray image is given below. What's the diagnosis? So you can see here, this is the coin. And guys, can you tell me where is the coin? You can see the coin. Since patient is having dysphagia, and this is chest X-ray PA view, and on chest X-ray PA view, we can see flat surface. On chest X-ray PA view, you can see flat surface, and if you go for lateral view, on lateral view, we can see the edge. Clear? So on the lateral view, we can see the edge. This is esophagus. And whenever coin is in trachea, what is the symptom? Dyspnea. And if you go for PA view, on that, there you can see the edge of coin. On lateral view, you can see the flat surface. So here, it's not in the trachea, because here the symptom is dyspnea. Obviously, it's not in the lungs, obviously not in pleura. What correct answer is? Foreign body is there in the esophagus. So here the coin is there in the esophagus. Next question. A patient who underwent surgery for lipoma 5 weeks ago now presents with a scar where at the incision site, remember, limited to the original wound boundaries. It's limited to original wound boundaries. What's the most likely diagnosis? Tell me. It is keloid or it is hypertrophic scar. What's the basic difference? Similarity, both of these are having excessive scar tissue. Difference, in hypertrophic scar doesn't extend beyond the wound margin or beyond the incision. But keloid extends beyond the wound margin or incision. So here, correct answer is hypertrophic scar. Similarity between keloid and hypertrophic scar, in both there is excessive scar tissue. Here, it extends beyond, it extends beyond. So here it extends beyond wound margin or incision. So extends beyond wound margin or incision. Beyond wound margin or incision. Clear? But hypertrophic scar, it doesn't extend. It doesn't extend beyond the wound margin or incision. Clear? So correct answer is hypertrophic scar. What is the special feature of keloid? You know what? Usually these are painful. Most common site is sternum and it is seen in darkly pigmented races. Right? Correct answer is C. See this question. What would be the subsequent course of action for this injury depicted in the image after 3 days period following road traffic accident? Now see this injury. What you can see, guys, you can see the gangrenous areas also. Can you see? Yes, there are gangrenous areas. Most probably patient is having necrosis of the tissues. Clear? And if there is necrosis of the tissues, what will happen? These patients are having sepsis. Sepsis. So what you have to do? Why? Because after road traffic accident, what will happen? There is contamination. So whenever there is necrosis, there is sepsis, you have to go for debridement of the necrotic tissue. What is the biggest problem? Whenever there is excessive soiling of any tissue, especially after road traffic accident, gas gangrene. So what? You are supposed to, remove the tissue so that there should not be any anaerobic environment. So what I have to go for? Excise this whole tissue. So all these gangrenous tissues should be excised, necrotic tissue should be excised, and after that, for faster healing, we give hyperbaric oxygen. So for faster healing, we are giving hyperbaric oxygen. So see the options. First option, debridement of necrotic tissue. Yes, correct. Primary closure? No. Primary closure should be done within 6 hours only after the trauma. But it should not be done. If you are going for primary closure, again it might promote an anaerobic environment leading to gas gangrene. Debridement of necrotic tissue and hyperbaric oxygen, correct. Amputation not required. Clean and close with rotation flap, no. So correct answer is option B. Clear? Now see the next question. 38-year-old man brought to the emergency department after sustaining road traffic accident. Clear? An injury to lower chest, right? On presentation, the patient is stable, vitals are normal, chest radiography shows clear lung field. Lung fields are clear. What is the next step? Management. Okay, now see the problem. Patient is having road traffic accident and injury is there to the lower chest, right? But X-rays show clear lung fields. So this is a case of blunt trauma abdomen. Simultaneously, there is injury to lower chest. So we should be having one investigation which is going to assess abdomen as well as thorax. And what is that? If you want to assess abdomen, yes, that is FAST. So first investigation done in patients of blunt trauma abdomen, FAST. But if you want to extend FAST to assess thorax also, you want to assess right as well as left thoracic view. Right and left thoracic region, it should be assessed. So here it is eFAST. And what is eFAST, guys? Extended FAST. So first, check it with extended FAST. Tube thoracostomy not required, CT chest not required, CT abdomen not required. So what we are going for? We are going for eFAST. And eFAST, that is extended FAST. How many views are there on eFAST, guys? 6 views. So what are the views? Yeah, in FAST there are 4 P's. What are those 4 P's? Pericardial sac, perihepatic region, perisplenic region and pelvis. Pericardial sac, perihepatic region, perisplenic region and pelvis. And eFAST 6 views, 2 additional views, right thoracic, left thoracic. So correct answer is option A. Okay. Now see the next one. Which lymph node is most commonly involved in prostate cancer? Very easy question. Tell me first, what is the location of prostate in the body? Prostate, it's located in pelvis. Tell me, what is the location of bladder in the body? Urinary bladder. Bladder, it is in pelvis. Clear? Prostate is in the pelvis. Bladder is in the pelvis. So both in carcinoma bladder as well as carcinoma prostate, which lymph node is involved? Pelvic. Pelvic lymph node is involved. And in pelvic lymph node, which lymph node? This is obturator. So in pelvic, which lymph node? Obturator. So pelvic, in pelvic, it is obturator. Clear? So here it is not inguinal. In which malignancies there is involvement of inguinal lymph node? Carcinoma, anal canal, perineal malignancies, anal canal, carcinoma penis, carcinoma scrotum. So carcinoma penis, carcinoma scrotum. Perineal malignancies, there is involvement of inguinal lymph node. Yes, in carcinoma anal canal, first there is involvement of superficial inguinal lymph node. Retroperitoneal, it is involved in testicular tumor. Testicular tumor. In testicular tumor, there is involvement of retroperitoneal lymph node. And here, what is the correct answer? Correct answer is option D, that is pelvic. Clear? So it is option D, that is pelvic. Okay. Now see the next one. What is this? Can you see this? It is linear stapler. Now see the anastomosis. Imagine this is the GIT. This is the GIT. If you go for end-to-end anastomosis, imagine this is one end, this is another end, and you go for end-to-end anastomosis. So what kind of stapler is required, guys? Tell me. Yes, can you see the shape? Circular stapler is required. So if circular stapler, this circular stapler, this is usually for circular or end-to-end anastomosis of bowel. End-to-end. Now just imagine this is ileum and this is ileum. Okay. You want to do side-to-side anastomosis. So insert one limb here and insert one limb here and fire the stapler. So what is this? This is side-to-side anastomosis. So linear stapler. This is for side-to-side anastomosis. This is for side-to-side anastomosis. Clear? So you can see this is linear stapler used for side-to-side anastomosis. Skin stapler, obviously we are using skin stapler for skin suturing, means for closing the skin. And there is curved stapler, especially in hemorrhoid surgery, hemorrhoidectomy, we are using curved stapler. Again, it is circular stapler. So circular, end-to-end anastomosis, and linear, side-to-side. Clear? So here it is linear stapler. Correct answer is option A. Next question. You can see 25 years old patient presented to surgical OPD with painless left inguinal reducible mass, most probably hernia. On examination, you can see cuff impulse is positive. After further investigation, the patient is diagnosed with inguinal hernia. What is the surgical management? So you know, any patient who is having inguinal hernia, tell me the gold standard treatment. It is Lichtenstein repair. And what is Lichtenstein repair? Here, we are using mesh. So that is known as hernioplasty. So the gold standard repair, it is Lichtenstein repair, tension-free repair. So this is Lichtenstein. So this is Lichtenstein repair, and that is gold standard. So we go for hernioplasty, in which cases we are doing herniottomy. Herniottomy is done in children. Second, patient is having congenital hydrocele, or if there is strangulated or infected tissues. So whenever obstructed or strangulated hernia is there, after surgery you perform herniottomy. Don't use the mesh. Wait and watch? No, because what? Surgery should be done. Surgery is the only treatment for hernia. Emergency laparotomy is not required. Emergency laparotomy is required in which cases? Whenever there is emergency like obstruction or strangulation. So correct answer is option B, that is hernioplasty. Okay. See the next question. Identify the most common pancreatic islet cell tumor associated with Men's syndrome. Let me tell you, very easy to remember. Mnemonic is PGI. It is PGI. P means P-poma. P-poma means it is arising from PP cells, that is pancreatic polypeptide. So this is P-poma, pancreatic polypeptidoma. After that G means gastrinoma, and after that insulinoma. Okay. Another question, tell me, P-poma is functional? No, it is non-functional. It's non-functional. Gastrinoma is benign or malignant? This is malignant. And insulinoma, this is benign. Now see the questions. There are three kinds of questions which are asked. First, most common tumor associated with MEN1, islet cell tumor, P-poma. Most common functional islet cell tumor with MEN1, gastrinoma. Most common functional and benign neuroendocrine tumor with MEN1, insulinoma. Clear? So here P-poma is not given, and most common pancreatic islet cell tumor is asked. Correct answer is what? G, that is gastrinoma. Okay. Correct answer is option B. Now see the next question. Identify the procedure. Can you see, guys? What is this? You can notice here. What's the problem? Yes, clearly you can see what? This is IVP. On this IVP, you can notice that there is bilateral hydroureteronephrosis and typical appearance. Can you see? What is this typical appearance? This is adder head or cobra head appearance. Name adder head. So this is adder head or cobra head appearance. And you know that this patient is having what? Bilateral ureterocele. What is the name of this investigation? This is IVP. So what's the name, guys? You know, This is intravenous pyelogram. Correct answer is option C. What happens in retrograde pyelogram? You inject the dye from below. Imagine from the bladder, I'm going into ureter, and from ureter, I'm injecting the dye from below. And then take X-ray. This is RGP. In which cases you are going for RGP? Imagine there is obstruction and you want to assess the ureter distal to obstruction. So in that case, you perform RGP. Clear? So this is what? IVP, intravenous pyelogram. Okay? Correct answer is option C. Now see the next one. Very easy question. What is the probable medical condition for 80 years old male, 80 years, who experienced pain and swelling in the calf on the right side after being immobilized due to fracture in right intertrochanteric region? Easy question. So here there is immobilization. Clear? Because of this immobilization, patient started having pain and swelling in the calf. Classical description of DVT. What happens in DVT? You know, there is Virchow's triad which is positive in DVT, guys. Virchow's. Can you tell me what are the components of Virchow's triad? Endothelial injury, stasis and hypercoagulable state. So here what is the stasis? There is immobilization after fracture because you performed what? You performed the surgery or you applied the plaster cast, and after that patient is having pain and swelling in calf. Question: what is the most common site of DVT? Calf or soleal vein? Calf or soleal vein. What is the most common symptom of DVT? There is pain and swelling in the calf muscle or calf region. So what is the correct answer? It's not osteomyelitis, right? Because osteomyelitis, it presents quickly. I mean within 7 days, 10 days, if infection is there. It is DVT. It is not compartment syndrome, because what happens in compartment syndrome? There is pain, there is paresthesia, there might be paralysis or pulselessness. It is very painful. It is not arterial claudication. So correct answer is option B. Okay. Now see the next question. Very easy. A barber aged 42 years. See, the occupation barber means mostly barbers are cutting the hair in standing position, obviously. 42 years. He is having healed ulcer given as below over the lower medial aspect of right leg, medial aspect. Okay. On examination, he has varicose vein. So the clue is already there. Varicose vein is there. So what is the most likely type of ulcer? Guys, it is venous ulcer or varicose ulcer. Typically, it is seen in Gluteus region, just above or 1 centimeter above medial malleolus. What kind of edges are there? Sloping edges. So this is what? Venous ulcer. Venous ulcer. In which patients there is neuropathic ulcer? The patients who are having tapes dorsalis, or patients who are having, sensation, means nerve-related abnormalities, patients who are having diabetes. So at bony prominences, if the sensation loss is there, there is neuropathic ulcer. Arterial ulcer, the areas which are very prone to ischemia. It is intensely painful, so it is present at shin of tibia and bony prominences. Tubercular ulcer, there will be history of tuberculosis, and what kind of edges will be there, guys? Undermined. So undermined edges in arterial ulcer, this kind of edge, what? This is known as punched out, and this image, patient is having varicose vein, and this kind of edge is there. What is the name of this edge, guys? Sloping edge. So important point, prolonged standing, patient is having varicose vein, so obviously ulcer is venous ulcer. Correct answer is option C. Right? Now see the next one. Very easy question. See this, 45 years old woman presents to emergency room with severe right upper quadrant abdominal pain. There is nausea, there is vomiting. She gives the history of gallstones and diagnosed at acute cholecystitis. During lap chole, surgeon encounters difficulty identifying the cystic artery due to inflammation. Which anatomical landmark within Callert's triangle would be most helpful in locating the cystic artery? Now it's very easy. First, tell me what are the boundaries of Callert's triangle. Easy question. This is liver. Guys, liver. After that you can see. Yes. What is this? This is common hepatic duct. This is cystic duct. And you can see this is cystic artery. So this is Callert's triangle. This is cystic artery. Right? Here, what happens? In the Callert's triangle, there is a lymph node. That's the content of Callert's triangle. What is this lymph node? This is known as cystic lymph node. Cystic lymph node, or known as lymph node of Lund. This is known as cystic lymph node, or known as lymph node of Lund. So it helps in localization of cystic artery. So it's fundus, obviously not. CBD, portal vein, obviously not. Cystic lymph node. Cystic lymph node. So important questions. What are the boundaries of Callot triangle? Common hepatic duct medially, cystic duct laterally, superiorly, cystic artery, and the content, cystic lymph node, also known as lymph node of Lund. Correct answer is option B. Now see the next question. Very easy. What is the most common site of gastrinoma in Zollinger-Ellison syndrome? You know, it is duodenum. You know, guys, it is duodenum followed by pancreas. And can you tell me which part of duodenum? Tell me which part of duodenum? You know, it is D1 followed by D2 followed by D3, and it is not seen in D4. There is common mistake done by students. What? They mark second part of duodenum. No, it is first part of duodenum. So correct answer? It is first part. This is first part of duodenum. Correct answer is option C. That is first part of duodenum. Clear? Next question. 55 years old female presents with history of abdominal surgery performed 3 days ago. Abdominal surgery, 3 days. She reports worsening abdominal distension. After surgery, patient is having abdominal distension, did not pass stool since the surgery. So non-passage stool. On examination, abdomen is distended. Bowel sounds are absent. Which of the following statement is correct regarding this condition? First tell me, this is obstruction or ileus? In obstruction, what happens? There is hyperperistaltic activity. So hyperactive bowel sound will be there. In ileus, there is ileus, paralytic ileus because of surgery. So what will happen? The bowel sound will be absent. In both of the cases, there is abdominal distension and there is non-passage of feces and flatus. So see, which of the following is correct? It is caused by increased peristaltic activity. No, there is decreased peristaltic activity. Surgery is the first line treatment. No, because what happens here? Conservative management. Sometimes overhandling of bowel, excessive fluid, sometimes anesthetic drugs, clear, opiates. There are medications which are responsible, and sometimes dyselectrolytemia like hypokalemia is responsible. So this is not the first line treatment. Usually we insert Ryle's tube and conservative management. Treat the underlying cause. X-ray shows dilated bowel loops, air fluid levels, correct. Patient is having abdominal distension associated with hyperkalemia. No, it is associated with hypokalemia, right? So what is this, guys? This is paralytic ileus, a type of paralytic ileus that is known as post-operative ileus. After surgery, post-operative ileus, majority of patients are going to improve after conservative management. Hypokalemia is one of the cause. Here, peristaltic activity is almost nil or absent. So correct answer is option C. Option C. Next, very easy. Which of the following statement is true about acute appendicitis? True. First, diagnosis in children can be done by clinical signs only. No, kids are not going to tell all the signs and symptoms. They are not very cooperative during examination. That's why here in children, investigation of choice is ultrasound. Investigation of choice is ultrasound. Next, diagnosis in adults requires additional imaging modalities. Additional imaging modalities. Usually, guys, it's the clinical diagnosis. So, acute appendicitis, usually it's clinical diagnosis. So, always it is not going to require additional imaging modalities. Gold standard is not ultrasound. It is CCT. CCT will rule out or it will confirm the diagnosis whether patient is having acute appendicitis or not. So, it is CCT. A shift to left in leukocyte count is seen. Yes, there is shift to left. This is correct. There are immature cells. So, this is correct. Correct answer is option D. Okay. Now, see the next one. 24 years old burn patient. Burn patient is receiving fluid resuscitation and being closely monitored. Ideal urine output. It should be 0.5 to 1 ml per kg per hour. Ideally, it's 1 ml per kg per hour or 1 ml per minute. If you calculate 1 ml per minute, it is 60 ml per hour. And if ideal reference adult has to be considered and the weight is 60 kg, so you calculate this also. This is also how much? 60 ml per hour. So 1 ml per minute in adults or 1 ml per kg per hour in children. It is 0.5 to 1 ml per minute. In children, so in adults, what's the correct answer, guys? The correct answer is here. Correct answer is option A. Clear? Now see the next question. Very, very easy. See, first look at this and tell me what's the diagnosis. Just by looking at this, you can make out that this is ranula. Now see the question. A 16-year-old female has painless, soft, fluctuant swelling in the anterior floor of her mouth. Has increased in size over 5 weeks. There is no history of trauma or infection. What is the most appropriate next step in confirming the diagnosis? Usually, diagnosis is clinical, but you can see the extent that what is the relation of this ranula or this extravagation cyst with nearby structures. So soft tissue relation you have to assess, and this relation is best assessed by MRI. So this soft tissue relation is best assessed by MRI. Here CT is not done usually. Incisional biopsy or aspiration is not done. So correct answer is option A. And guys, you must be knowing what is the treatment for ranula. We go for marsupialization. What we are doing, guys, we are going for marsupialization. And if there is recurrence after marsupialization, then you can go for excision. So if there is recurrence, then you go for excision. Otherwise, we are going for marsupialization. Got it? So correct answer is option A. Okay. See the next question. Very easy question. You can see road traffic accident patient stabilized with no severe external injury. No severe external injury. But there is tachycardia, weak pulse, hypotension, tachypnea. Why? If there is no external injury, there must be internal injury. And because of this internal injury, what's the big problem? Patient is having shock, weak pulse, hypotension, tachycardia, tachypnea. Why? The most common cause of shock in road traffic accident patient or trauma patient, guys, patient must be having internal bleeding. Patient must be having internal bleeding. Clear? So which ATLS primary assessment component is most likely causing these symptoms? It is A, B, C, D, E. A, B, C, D, E. A means airway, B means breathing, C means circulation, D means disability, E means exposure with environmental control, right? If patient is having shock management, fluid resuscitation, all these are included in circulation. So this patient is having hypovolemic shock because of bleeding. It's not related to airway, not related to breathing. It is related to circulation. So this is not neurological or hypothermia. This is related to circulation. Correct answer is option B. Next question. After major earthquake, a patient presents with compound fracture and spinal injuries. Considering the severity of these injuries and urgency of treatment, which triage color code is most appropriate? So triage tag. Triage means to sort. What are the color codes? It's red, yellow, green, blue, black. Red means immediate or emergency treatment is required. Why? Because this patient is having life-threatening injuries, like patient might die within hours, within minutes. Example, tension pneumothorax. Tension pneumo. Patients who are having massive hemothorax, massive hemo, or the patients who are having what? EDH. Clear? It's life-threatening situation. Second, yellow. It is serious but not immediately life-threatening, means within hours patient is not going to die. But if ignored, patient might die. Classical example, yellow. Patients who are having compound fracture. The patients who are having compound fracture are patients who are having visceral perforation. So compound fracture or visceral perforation. Immediately patient is not going to die, but ultimately patient is going to die. So here it is serious but not immediately life-threatening. Green. Yes, here delayed care means patient who is having simple fracture or laceration. In this case, patient can go to the hospital on his own. Simple fracture or laceration. What do you mean by black, guys? Black. Black is patient is already dead. What is blue? Blue, patient is having significant injury for which resources are not available. Extensive treatment is required. Resources are not available. Imagine patient is having extensive brain injury. Patient is in the vegetative state and you don't have the resources available, right? So here you can see patient is having compound fracture, spinal injury. So this is yellow. Urgent care should be provided. So correct answer is yellow. D. Next question. 45-year-old male brought to the emergency room after car accident with penetrating injury to the left chest. eFAST reveals fluid accumulation in pericardial sac. Which of the following is not a component of Bake's triad? Classic finding in pericardial tamponade. You know, rapid collection of fluid can cause pericardial tamponade, especially in trauma patient. And how to remember, guys, this Bake's triad? The mnemonic is MDH. MDH means asli masale such. So MDH, can you tell me M? M is muffled heart sound. You can see M, muffled heart sound. D is distended neck veins. Distended neck veins, and H, that is hypotension. So MDH, muffled heart sound, distended neck veins, hypotension. Bradycardia is not the component. So bradycardia is not the component of Bake's triad. So correct answer is option C. See the next question. Very easy question. 10 years old child. Usually adults are asked in road traffic accident. See this question here. 10 years old child is brought to the emergency department after a road traffic accident. He is in severe respiratory distress with hypotension. There is tracheal deviation to the left, absent breath sounds on the right side. What's the problem? Hypotension, respiratory distress, absent breath sounds. It means excessive collection of air. This patient is having tension pneumo. Guys, patient is having tension pneumothorax. And if there is tension pneumothorax, on the basis of suspicion only, because the clinical diagnosis, put a wide bore needle in second intercostal space in mid-clavicular line in children and fifth intercostal space in anterior axillary line in adults. Patient is a child. Where are you going to insert the needle? Second intercostal space in mid-clavicular line. And if patient is an adult, here insert a wide bore needle. In adults, insert a wide bore needle in fifth intercostal space anterior to mid-axillary, that is known as anterior axillary line. After that, we have to go for treatment of choice, and that is ICD insertion, obviously, in the fifth intercostal space in anterior axillary line. So correct answer is option D. Correct answer is option D. Clear? Now see the next question. Next question. 48 years old female presents with fluctuating muscle weakness. Fluctuating myopathy might be there. Difficulty in speaking. Drooping eyelid that worsens with physical activity. Classical manifestation of what? Myasthenia gravis. There is a mass in anterior mediastinum. Can you tell me which mediastinal mass is associated with myasthenia gravis? Guys, tell me which is located in anterior mediastinum. You know, thymoma. It is thymoma. Clear? So which of the following is most likely paraneoplastic syndrome associated with her condition? So you know, with thymoma, there is myasthenia gravis association. There is fluctuating muscle weakness, difficulty speaking, drooping eyelids, and it is going to worsen with physical activity. So correct answer is option B. So these were the questions, guys. I hope you did it nicely in the exam. All the best.
Hello everybody, so welcome to PSM Pulse Test questions. The first question was, which of the following vaccines are contraindicated in pregnancy? We know pregnancy is immunosuppressed state, so live vaccines are contraindicated. Now if you look at the options, influenza is available both as live and killed. If you look at rabies, it is a killed vaccine, and if you look at Tdap, of course it's a toxoid. So what is the correct answer over here? Varicella. Varicella is available only as a live vaccine. Okay? Varicella is available only as the live vaccine. Moving to the next one, which of the following is a formula for sensitivity? Sensitivity is ability to identify correctly all those who have the disease. The correct formula over here is Tp upon Tp plus Fn into 100. If you talk about specificity, this is the formula for specificity. And if you talk about positive predictive value, everything positive. So this is PPV, and everything negative is negative predictive value. Moving ahead, in a study based in Delhi, doctors followed 100 people who did exercise for a year, and later they checked all those who developed coronary artery disease. What type of study is this? Is it case control? Is it prospective study, cross-sectional study, cohort? Now what is happening over here, guys? We are moving from exposure to outcome, right? But of course, we're not going from effect to cause. So therefore, it's not case control. Cross-sectional, because we're not doing it at the same point of time. Now what will you select from prospective and cohort? cohort study. Cohort study could be prospective or retrospective also. So what is the better answer over here? Prospective. We've selected a group of people, we are asking them about their exercise, and then we are following them for CVD. So over here, better choice would be prospective. If prospective study was not in the option, then of course I would have gone with cohort study. Next one, which of the following is management of a HIV positive patient with multiple dog bites? Now, of course, multiple dog bites definitely is category C. In category C, we do wound management, we also give rabies vaccine, and we also add immunoglobulin. But remember one thing with HIV positive patients, even in category 2, we will be giving immunoglobulin. Okay? Okay. Which of the following is correct arrangement about levels of healthcare? So for levels of healthcare, guys, at primary level, you have sub-centers in PHCs. At secondary level, you have CHCs. And at tertiary level, you have medical colleges. Okay, so if you look over here, the first one is wrong because primary level में medical colleges and hospitals नहीं है. This is wrong because secondary level में sub-center is not there. It's always in primary level. But if you look at the option, again, C is wrong. The correct answer is B. Primary level, sub-center PHC, secondary level CHC, and medical colleges and hospitals are tertiary. Moving ahead, an image of the mascot is shown below. So we all know a girl wearing a school bag. Okay, she is nothing. She is Wu. She is Sapna. Sapna was a cured case of leprosy, and she was adopted as an initiative under the Sparsh program. Okay, Sapna mascot. She was adopted under National Leprosy Eradication Program to spread awareness on leprosy, and she is an inspiration from Meena. Meena is the image with the parrot behind. Okay, that is for child's right. Next one, which of the following is the population norm for an OSHA worker? So OSHA worker is in an urban slum, 1000 to 2500. If you have to look at one value, average would be 1000. Okay, average would be 2000. ASHA worker existing 1 per 1000. But if they give it OSHA worker, 1000 to 2500. Next one, identify the deficiency in the image. So this, as you all know this, we have done this many times. Acrodermatitis enteropathica, which is deficiency, this is an inherited defect in the uptake or in the absorption of zinc cells. Okay, so this is acrodermatitis enteropathica. And the very characteristic findings in this is that you're going to see inflammatory rashes around the lips, cheeks, also around the anal region. Moving ahead, a factory worker sustained burns covering 25% of his body while on duty. He later developed infections and complications. So under ESI Act. Now under ESI Act, if anybody who suffers more than 20-degree burns with complications, okay, with empyema, complications, infections, okay, they are subjected to get access to extended sickness benefit. Like TB में भी होता था. Extended sickness benefit, we all know, is 80% of wages for 2 years. TB, leprosy, HIV, all these diseases, plagias, burns, we get extended sickness benefit for 2 years. Now look here, a woman develops edema, this was important, visual disturbances and heart failure after consuming a food item. Now edema was your buzzword, alright, non-inflammatory नहीं लिखा हुआ है, but edema लिखा हुआ है, so non-inflammatory edema, also heart defects can occur. So this is a classic example of epidemic dropsy in which there is contamination of mustard oil with argemone oil. And what is the toxin here? Sanguinarine. Next question, what are the potential health risks faced by workers in a sugarcane factory? Anthracosis, siderosis, bagasosis, bisonosis. So we know sugarcane, G for bagasosis. Bisonosis is cotton dust. Next one, heart of sewage disposal. Now heart of sewage disposal, basically we are referring to the activated sludge process in which we have an aeration tank. So basically heart of that is aeration tank. This is a part of activated sludge process, which is an example of secondary sewage treatment. A gym owner observes that individuals who drink iced tea during their workout tend to lose more weight. What is the nature? Now, see, what he's trying to do is, a gym owner is trying to find out correlation between iced tea and during workouts and losing more weight. But actually, there's no such association. So what is this example? This is an example of spurious association. Moving ahead, in the context of new onset of a morbid disease, how does the change in incidence affect the prevalence? Now see, whenever I talk about morbidity, morbidity means the burden is increasing. So morbidity means the incidence and prevalence of disease is increasing. So when incidence of a disease increases, that means new cases increases. We know P is equal to I into D. So with due course of time, if incidence is increasing, if there is no quick recovery or no death, they will continue adding to the existing disease load. So what is going to happen in due course? Prevalence will also increase. So what is going to happen? Incidence and prevalence will increase. All right, moving ahead, what concentration of fluoride is typically associated with causing crippling fluorosis? So crippling fluorosis, genu valgum, this is more than 10 milligram per liter. Okay, in a subcenter population, CBR is 20. What is the minimum number of population registered with ANM? Now, we all know that if we talk about CBR is 20 per. So, CBR means for every 1,000 population, the birth rate is 20. So, subcenter May population is 5,000. So, for every 1,000 population, guys, the birth rate is 20. Right? So for every 5,000 population, what is going to be the birth rate? 20 upon 1,000 into 5,000. So that is 100. So we would expect 100 pregnancies. But obviously there would be certain abortions and there would be certain pregnancy wastage factors. So I've told you, you always have to consider 10% of pregnancy wastage factor. You have to consider 10% of pregnancy wastage factor. So what does this mean? That the number of expected pregnancies, all right, number of expected pregnancies would be, now if you look over here, 10% of pregnancy wastage factor, that means I will have to do, what is the pregnancy wastage that I'm going to expect? 10% of 100. Okay, I will expect 10% of 100. So I will be expecting 10 pregnancies as waste. So now number of expected pregnancies would be 100 plus 10, which is 110. Always add the pregnancy wastage factor. How will you calculate this? Whatever pregnancies we are expecting, of those, uska 10%. Then number of expected pregnancies 110. And now I've asked you minimum number of pregnancies registered. So at any one point of time, 50% pregnancies are registered with ANM. So if I'm expecting 110 by 2, so how many pregnancies would be registered? 55. Okay. Moral of this story, please remember 10% pregnancy wastage factor has to be considered, and expected pregnancies may you have to add it. And what is the minimum number of pregnancies that have to be registered with ANM at one point of time? That you always have to consider 50% of expected pregnancies. Moving ahead, which of the following disease does not follow spectrum of disease? So spectrum of disease means it can't be hidden. Okay, there cannot be subclinical cases, carriers. No, you will always have a case. Leprosy you do have, influenza it can stay hidden, TB also, but rabies it does not follow spectrum of disease principle. Next one, which vaccinations can be given to a 13-month child who has never been immunized? Now, so 13 months. So basically, this is a question of delayed immunization. BCG can be given in 1 year. Hepatitis B 1 year. OPV, of course, 5 years. DPT first dose and OPV, of course, first dose. DPT can be given till 7 years. OPV can be given till 5 years. But if you look at B, we can give it. Even option D, I can go, but I'll go with option C because all of these can be given to a 13-month-old. DPT can be given till 7 years, OPV can be given till 5 years, and measles can also be given till 5 years. Next one, which of the following is known as the final impact indicator in National Family Planning Program? So final impact indicator we all know is net reproduction rate. For a country's population to stabilize, TFR should be equal to 2.1, which is two child norm, and for this net reproduction rate will be equal to 1. Okay, and couple protection rate has to be more than 60% or contraceptive prevalence. Moving ahead, which of the following statements about KMC is incorrect? KMC involves early and prolonged skin-to-skin contact, yes, between the infant and the mother. It is meant for clinically stable low birth weight infants, yes. And exclusive breastfeeding is a part of it. KMC should only be provided in hospitals under skilled supervision and proper guidance. KMC helps stabilize body temperature, promotes breastfeeding, and prevents infection. Yes, this you don't need it under skilled supervision. It could be done. We just have to teach the mother, and she can do skin to skin contact of the mother with the baby, particularly for low birth weight. All right, next one. A 50-year-old man presents with severe abdominal pain, confusion, and difficulty walking, pallor. So facial pallor, first presentation, blue-black lines on the gum, as you can see over here, Burtonian lines, and foot drop, wrist drop, foot drop. So what metal poisoning are we referring to? Lead. Next one, which is not an ASHA role, providing counseling on birth preparedness and safe delivery. She does that. Administering vaccines, no, she will not give vaccines. She will not conduct a delivery. Yeah, she has to ensure vaccination completion. Mobilize the community for health awareness programs. Yes, provide dots also for TB. Next one, which counseling approach is used in family planning to provide structures and supportive communication to clients? So we all know it is gather approach. Greet the couple, ask them what they want, tell them, help them choose, explain to them, return to follow. Spike's approach was to break a bad news to the patients. And these are basically flannel graphs and flip charts are health education techniques. Next one, which of the following obesity indicators is considered the most useful single measurement? Now, most useful single measurements we could go for waist circumference also. Okay, that's like all of them can be used, but most useful single measurement if we have to do, we can assess for waist circumference. Which of the following types of surveillance is not used in National AIDS Control Program to track and understand HIV/AIDS epidemic? Now, we always do behavioral surveillance. We can also do sentinel surveillance. Passive hospital reporting kahin na kahin chal jati. Environmental surveillance has no role over here. Okay. Which of the following is the correct composition of new ORS? So we know new ORS, total osmolarity 245. You have it at 3 places. So this is your correct one. Sodium 75, glucose 75, potassium 20, chloride 65, and citrate 10. All right, next one, a 5-year-old child presents with sore throat, low-grade fever, a grayish membrane on the tonsils and swelling of the neck. What statement about carriers of this infection? So basically, the case that you've got with a grayish membrane means pseudomembrane, that's an active case. But the question is being asked about carriers. Carriers are asymptomatic. Yes, they are asymptomatic, but they require no treatment. No, they do require treatment. Yes, they should receive antibiotics. Erythromycin de do. Okay? Carriers can be identified by grayish membrane. No, if you have grayish membrane, it's an active case. Carriers don't have pseudomembrane. Carriers are insignificant in disease spread. No, they are most significant in disease spread. Okay, so over here the correct answer was carriers should receive antibiotics to eliminate bacteria and prevent transmission. So that's it. Thank you so much.
Hi everyone, welcome to the test and discussion session. The test that you attended recently is FMGE Pulse exam. And now let's discuss all biochemistry MCQs that were asked in that test. Okay, so the first MCQ is this. It's an image-based MCQ. As you can see in the image, there are rashes, right? Lesions in the perioral region. And we call it as acrodermatitis because it is seen in the periorificial region and it is most commonly seen in the palms, in the extremities. So this part of the definition or the explanation represents acrodermatitis. And the child also presents with a history of diarrhea. This is enteropathica. Enteropathica meaning intestine is affected, that presents as diarrhea. So this is classical of acrodermatitis enteropathica, which is caused by zinc malabsorption that causes zinc deficiency. So the right answer here is zinc deficiency. This is a very popular MCQ as far as FMG exam is concerned. So whenever you see periorificial lesion and if the history also says in the periphery there are lesions and if there is history of diarrhea, always think of acrodermatitis enteropathica, which is caused by zinc malabsorption. So the answer for this question is choice A. Had it been niacin deficiency, again you would see dermatitis, diarrhea and dementia. So even here dermatitis, diarrhea, and dementia. Here you don't see anything related to dementia, but also the dermatitis that you see, niacin deficiency or pellagra, will be in the sun exposed area. Right, you see Castle's necklace. Here you don't see Castle's necklace. Here it is periorificial region. This is how you differentiate zinc deficiency and niacin deficiency. Okay. The next MCQ, a very simple, again a very popular MCQ. The development of cataract in patients with diabetes is primarily due to the accumulation of which of the following substances in the lens? The answer is sorbitol. Okay, let me explain how sorbitol is formed in the lens in diabetes. It is because diabetes is absolute or relative insulin deficiency. Whenever there is absolute or relative insulin deficiency, all those tissues which are dependent on insulin for glucose uptake cannot take up glucose from the blood. So what are the tissues which are dependent on insulin for glucose uptake? Skeletal muscle, cardiac muscle, adipose tissue, hepatocytes. So all these cells will not be able to take up glucose from the blood. The result is there is excess glucose within the blood. That causes hyperglycemia. This excess glucose then starts entering into those cells which don't need insulin for glucose uptake. What are the cells which don't need insulin for glucose uptake? Lens. So lens takes up excess glucose. Within the lens, if it exists as glucose, we don't have to worry, because through the same transporter through which glucose enters into the lens, it can also come out. But what happens is, lens has an enzyme by name aldose reductase. What does aldose reductase do? I am writing the name of the enzyme. Aldose reductase acts on glucose, which is an aldehyde, converting glucose into an alcohol. That alcohol that you get is called as sorbitol. Once sorbitol is formed within the lens, it cannot come out of lens. It gets trapped within the lens. Sorbitol is osmotically active. It attracts water. So lens fibers swell and that begins cataractous changes. So which enzyme is responsible for diabetic cataract? It is aldose reductase. Which alcohol is responsible for diabetic cataract? It is sorbitol. So what is the right answer here? The right answer here is choice A, sorbitol. Had the question been about galactosemic cataract, galactosemic cataract is because of galactitol or dulcitol. Both are the same. Galactitol is otherwise called as dulcitol. I hope you all remember galactosemic cataract is described, right? Galactosemic cataract is described as oil drop cataract. And that oil drop cataract is because of the accumulation of which alcohol? Galactitol or dulcitol. Okay. A child presents with abdominal distension and an enlarged liver by 8 cm below the costal margin, right? Which is massive hepatomegaly. And the liver is smooth on palpation. Which of the following is the most likely diagnosis? The right answer is glycogen storage disease. How did I exclude other choices? I know for sure this is not lysosomal storage disease. Had it been lysosomal storage disease, the abdominal distension would have not only be caused by liver enlargement, that should have also been splenic enlargement. Right? Lysosomal storage disorders present with hepatosplenomegaly. Here they have not mentioned anything about spleen enlargement, so it's most probably not lysosomal storage disease. Okay, and how did I exclude hepatocellular carcinoma? Age. A child presenting with hepatocellular carcinoma is very uncommon. I'm not saying never possible, it is uncommon, it is also possible, but if it was hepatocellular carcinoma, the liver will not be smooth on palpation. The liver will be hard and the liver will be nodular. Right? That is why this is not most probably hepatocellular carcinoma. How did I exclude autoimmune hepatitis? Autoimmune hepatitis never presents with massive hepatomegaly. So the right answer here is glycogen storage disease. This is how you have to exclude other choices. Okay. The next MCQ. A patient presents with gum bleeding. The moment you see gum bleeding, you should think of scurvy. Scurvy, which is caused by vitamin C deficiency. because vitamin C deficiency causes bleeding, which will manifest itself as gum bleeding and petechiae. So why should vitamin C deficiency cause gum bleeding, petechiae and poor wound healing? It is because vitamin C is necessary for collagen cross-linkage formation. So whenever there is vitamin C deficiency, collagen cross-linkage cannot get established. So subendothelial connective tissue is weak. That makes a blood vessel weaker. When blood vessel is weaker, that causes bleeding. So it presents as gum bleeding and petechiae. When collagen maturation does not happen, wound healing is not proper. Hence, the child will present with poor wound healing as well. So the right answer here is vitamin C deficiency, which causes scurvy. Scurvy presents itself as gum bleeding, petechiae and poor wound healing. Okay. The biochemical form of amyloid in hemodialysis associated amyloidosis. I'll tell you the right answer first. The right answer is A beta 2 microglobulin. Okay, reason. A beta 2 microglobulin belongs to MHC class 1 molecule, and this gets cleared off from the blood normally by kidney when there is kidney disease, chronic kidney disease, and if the patient is put on hemodialysis, if they were using primitive type of membrane for hemodialysis, that membrane does not clear off A beta 2 microglobulin from the blood. And when A beta 2 microglobulin accumulates, that gets deposited in many connective tissues. It gets deposited in bone. Okay, and that causes carpal tunnel syndrome. So hemodialysis associated amyloidosis because of accumulation of A beta 2 microglobulin. The answer is choice C. How did I exclude other choices? AL stands for amyloid light chain. The moment you hear the word light chain, you should remember immunoglobulins, because we know immunoglobulins have light chain and heavy chain. In any condition like multiple myeloma, wherein immunoglobulins are produced more, light chains are massively generated. Those light chains accumulate as AL amyloid. So AL amyloid is seen in multiple myeloma, not seen in hemodialysis. AA amyloidosis or secondary amyloidosis is seen whenever there is a chronic inflammatory condition. Okay. ATTR. TTR here stands for transthyretin. That is seen in senile amyloidosis. So the right answer here is A beta 2 microglobulin. Okay. Multiple myeloma presents with AL amyloidosis. Chronic inflammatory conditions present with AA amyloidosis. Senile amyloidosis presents with accumulation of ATTR. A 13-year-old presents with acute flaccid paralysis. Cerebrospinal fluid is collected and an RT-PCR test is ordered to identify the causative virus. When will you ask for RT-PCR? RT-PCR for all practical purposes mean reverse transcriptase PCR. When will you use reverse transcriptase PCR? When the nucleic acid that you get from the sample is RNA. Right? Only when the nucleic acid that you get from the sample here is cerebrospinal fluid. So whenever you're told that it is reverse transcriptase PCR, it tells you that it is an RNA pathogen that they are trying to detect. And the question is, which viral enzyme is responsible for replicating the genome of this RNA virus? In the virus, RNA will be replicated by RNA-dependent RNA polymerase. From RNA, I want another RNA. So, which enzyme will I be using? RNA-dependent RNA polymerase. So, the right answer for this question is choice D. Okay, but had they asked you which enzyme is responsible for replicating the RNA in reverse transcriptase PCR? In that case, your answer should be RNA-dependent DNA polymerase, which converts RNA to DNA, and then it is a DNA-dependent DNA polymerase that converts the DNA into DNA. So, you have to be very sure, right? You have to be very clear about the question that is asked. If they ask you which viral enzyme is responsible for replicating RNA in the RNA virus, it is RNA-dependent RNA polymerase. So without a doubt, the answer for this question is choice D. But to twist it, if they ask you in the process, in the technique, RT-PCR, which enzyme is responsible for replicating the nucleic acid, your answer should be DNA-dependent DNA polymerase. Because what do we do in RT-PCR technique? In RT-PCR technique, first using reverse transcriptase, we convert the RNA of the virus to DNA. And then we use DNA-dependent DNA polymerase to convert the DNA into multiple copies of DNA. Do you understand this? So in the technique, it is DNA-dependent DNA polymerase. In the organism, it is RNA-dependent RNA polymerase. So the answer for this question is choice D. Okay. A 40-year-old female working as a senior executive, mid-aged female, leading a sedentary lifestyle, presents to the OPD with palmoplantar pigmentation, right? Black pigmentation of palms and soles. X-ray spine shows calcification of intervertebral discs. On adding Benedict's reagent to the urine sample, it gives a greenish brown precipitate. So Benedict's test is positive. That is point number 1. Point number 2, palmoplantar pigmentation. Point number 3, calcification of intervertebral discs. All these mean it is alkaptonuria. Alkaptonuria presents with euchronosis. Euchronosis is joints getting involved. Okay, so you see calcification. And you know alkaptonuria, in alkaptonuria, patient's urine answers Benedict's test. So the diagnosis is alkaptonuria, which is caused by the defect of homogentisate oxidase. So the right answer here is choice C. How about other choices? Phenylalanine hydroxylase defect causes phenylketonuria. Phenylketonuria presents with what? It presents with mental retardation. Do you see mental retardation here? No. It presents with mousy odor. Do you see mousy odor here? No. It presents with hypopigmentation. Do you see hypopigmentation? No. Here it is hyperpigmentation. So this is not phenylketonuria. It is not phenylalanine hydroxylase defect. Okay. Tyrosine hydroxylase defect does not cause any of these inborn errors of metabolism. Tyrosine hydroxylase is responsible for the conversion of tyrosine to dopamine, neurotransmitter synthesis. So it has got nothing to do with any of the inborn error of metabolism features given in the question. Okay. Para-hydroxyphenylpyruvate dioxygenase defect causes type 3 tyrosinemia. Para-hydroxyphenylpyruvate dioxygenase defect causes type 3 tyrosinemia, which presents with intermittent seizures and ataxia. It does not present with pigmentation. It does not present with joint abnormalities. It presents with seizures and ataxia. So what is the right answer here? The right answer here is homogentisate oxidase defect, which is alkaptonuria. The next MCQ. A 6 months old infant presents with muscle hypotonia and heart failure. So heart failure is the classical finding that you should remember. Okay. So I asked you to remember heart failure. Heart is the pump of your body and heart failure is seen in Pompey's disease. Lab tests reveal an accumulation of glycogen in lysosome. I also told you Pompey's disease is the only lysosomal storage disorder, which is a glycogen storage disorder. So the diagnosis is clear. The answer is choice B, Pompey's disease, because it presents with heart failure and hypotonia. What about other choices? McArdle's disease can present with exercise intolerance. In McArdle's, wherein muscle phosphorylase is defective, it presents with exercise intolerance. It does not present with heart failure. Von Gerke's disease does not present with any muscle-related manifestations. Von Gerke's disease presents with hypoglycemia, severe fasting hypoglycemia. Cory's disease, it presents with both exercise intolerance and hypoglycemia. So please remember, McArdle's presents with exercise intolerance, von Gierke's disease presents with fasting hypoglycemia, Cory's disease presents with both intolerance and hypoglycemia. Pompey's, the pump is affected, it presents with heart failure, and it's a lysosomal storage disorder. Okay. The next MCQ. A 6 months old infant has been having developmental delays. Further examination reveals a defect in the enzyme called phenylalanine hydroxylase. So the diagnosis is straightforward. When phenylalanine hydroxylase is defective, you call that condition as phenylketonuria. Phenylketonuria, the urine odor that you observe is musty odor or mousy odor. So we know the answer is choice B, musty odor, because it is phenylketonuria. Okay. Now, when do you see fruity odor? Fruity odor is a feature of diabetic ketoacidosis. Yeah, you know diabetic ketoacidosis presents with fruity odor. Cabbage odor, I asked you to remember an image wherein a tire is repurposed to grow cabbage. Right? So, cabbage odor, tire, type 1 tyrosinemia. Please watch rapid revision video. In rapid revision videos, I've given you clues to remember urine odors of all these enzyme disorders. Okay. So, cabbage odor is a feature of type 1 tyrosinemia. Burnt sugar odor, we know, is a feature of maple syrup urine disease. So, the answer here is musty odor, which is a feature of phenylketonuria, which is caused by the defect of phenylalanine hydroxylase. A 2-year-old child presents with progressive bowing of legs and tenderness in the lower limbs. The child has a history of limited outdoor play and a diet low in dairy products, right? So what is it? Leg bowing, rickets, right? Because there is history of limited outdoor play and diet low in dairy products. All these will fit into a diagnosis of vitamin D deficiency, which is rickets. Okay, so how did I exclude all other choices? Blount's disease, yes, can present with bowing of the legs, but it is not going to be painful, right? It's a growth plate disorder. Growth plate disorder presents with bowing of legs, but it does not present with tenderness. And there is no relevance of Blount's disease and the history of limited outdoor play. Okay, so this is not Blount's disease. Osteomalacia, no, because osteomalacia is an adult disorder. Vitamin D deficiency in an adult presents with osteomalacia, not in a child. Osteogenesis imperfecta, no, because osteogenesis imperfecta presents with repeated bone fractures, blue sclera. I don't see any of that here, hence the answer is rickets. An infant is diagnosed with classical galactosemia. It's a one-liner. They are asking you which enzyme deficiency is responsible for this condition. We know classical galactosemia is because of the defect of Gal-put enzyme. What is Gal-put enzyme? Galactose 1-phosphate uridyl transferase. Yeah. Answer is choice B. It's a one-liner. A 45-year-old woman presents with fatigue and muscle weakness. Lab tests reveal hypoglycemia and elevated lactate levels. The physician suspects a deficiency in a coenzyme that is essential for gluconeogenesis. So, summary of positive findings: fatigue and muscle weakness is number 1. Number 2, hypoglycemia. Number 3, lactic acidosis. Number 4, they have told you it's a defect of a coenzyme that is necessary for gluconeogenesis. Based on this, what are the choices that I'm going to exclude first? I will definitely exclude fluoride first. Fluoride is not a coenzyme. We don't need fluoride, right? We don't need a fluoride as a coenzyme for any of the pathway. Actually, fluoride inhibits enolase of RBCs. It's an inhibitor. It is not a coenzyme. And then I would exclude magnesium. Magnesium is a coenzyme for few enzymes, but those enzymes are not related to gluconeogenesis, right? Then thiamine pyrophosphate. Yes, thiamine pyrophosphate is a coenzyme that is necessary for pyruvate dehydrogenase complex, which can convert pyruvate into acetyl-CoA. So whenever there is thiamine deficiency, PDH complex is inactive, pyruvate accumulates, and the accumulated pyruvate can form lactate. So I know thiamine deficiency presents with lactic acidosis, but it does not present with hypoglycemia. And it is not necessary as a coenzyme for a gluconeogenic enzyme, right? Pyruvate dehydrogenase is not an enzyme of gluconeogenesis. Hence, it is not choice B. So, what am I left with? I am left with choice C, biotin, because I know biotin is necessary for all carboxylases. Example for a carboxylase is pyruvate carboxylase, which is the first enzyme of gluconeogenesis, which converts pyruvate into oxaloacetate. Then pyruvate carboxylase is defective because of biotin deficiency. Pyruvate accumulates, that pyruvate becomes lactate. So yes, biotin deficiency presents with lactic acidosis. When gluconeogenesis is defective, that causes hypoglycemia. And this is an enzyme of gluconeogenesis. So everything that is given in the question aligns with choice C, deficiency or biotin deficiency. Okay, this is why you have to be very mindful when you read the question. Look at every statement as a clue. Take into account every clue, exclude choices, and then pick out the right answer. Okay, the next MCQ. A patient presented with reduced levels of high density lipoprotein. So the first one is low levels of high density lipoprotein and an ABCA1 mutation. And if you look at the image, you see grayish orange tonsils, right? Orange tonsil is a feature of Tangiers disease. Please remember, it's a feature of Tangiers disease. So what are the choices that I will exclude first? I am going to first exclude choice C, hyperlipoproteinemia, because the history says there is low level of HDL. Here it is not hyperlipoproteinemia. A beta lipoproteinemia of course presents with low levels of chylomicron, low levels of VLDL. It does not present with grayish orange tonsils, right? It presents with acanthocytes. For A beta lipoproteinemia, it is acanthocytes. So it is not choice B. It is not choice D. Ullmann's disease is caused by the defect of acid lipase. When acid lipase is defective, it presents with adrenal calcification, not with grayish orange tonsils. So the right answer is Tangiers disease. And I've already given you a clue to remember this. Tangiers disease, remember the tang juice. The most popular tang juice flavor is orange. So whenever you see grayish orange tonsils, remember Tangiers disease, which is caused by the defect of ABCA1 mutation, wherein there is reduced levels of HDL. So the answer is choice A. Okay, I hope you enjoyed this discussion. Thank you.
So hello friends, this is the video solution for the pulse test, the second pulse test, the OBS kinase section. Now look at the first question. Oral contraceptive pills are not protective for which cancer? Not protective. Answer is breast cancer. Please remember, oral contraceptive pills are protective for colorectal, endometrial and ovarian cancer. Oral contraceptive pills are associated with which cancer? Cervical cancer. And please remember, this is adenocarcinoma of the cervix, not the squamous cell cancer. Oral contraceptive pills are also definitely associated with hepatic adenoma. But please remember, hepatic adenoma is benign, it's not malignant. Oral contraceptive pills are definitely not associated with hepatocellular cancer and gallbladder cancer. Definitely not associated with these two cancers. What about breast cancer? Now, there are certain studies showing that, and there are earlier studies showing that oral contraceptive pill users, they have maybe may be a slightly increased risk of breast cancer. However, we also have studies showing that there is no increased risk of breast cancer in women who are using oral contraceptive pills, considering that the pills that are available and that are being used nowadays are the low dose oral contraceptive pills, right? So if you look at breast cancer and oral contraceptive pills, I will say plus minus as far as the risk is concerned or association is concerned, but definitely not protective, right? Next question pe jayenge. Now, during active management of third stage of labor, AMTSL, very, very important, hot topic, often repeated. You must be thorough with this. Which intervention is recommended to prevent PPH? So, when we are talking about active management of third stage of labor, all right, it is all the interventions have got to do with prevention of PPH, right? So, which intervention is recommended? Okay, is it oxytocin 10 units IM immediately after delivery of the baby? Yes, of course. Isn't it? Uterotonic is the most important intervention, right? And what is the drug of choice? Oxytocin is the drug of choice. 10 units intramuscularly as recommended by the Government of India also, right? Now, immediate administration of 20 units undiluted, absolutely not. IV bolus of any kind, oxytocin, absolutely not, can lead to dangerous side effects like dangerous tachycardia, hypotension, and even cause cardiac arrest as well. Okay. Now, rigorous fundal massage routinely combined with uterotonic agent. I have repeatedly said that massage, yes, is mentioned in the Government of India guidelines, but when you have already given a uterotonic agent, then routine, rigorous fundal massage is not necessary. It is not recommended by WHO. That is not your answer. Now, controlled cord traction with immediate removal of the placenta is also part of active management of third stage of labor, but it is only to be done when trained and skilled birth attendant is available. Okay, and this is not the most important component of active management of third stage of labor anyways, right? The advantage with controlled cord traction is that one shortens the duration of third stage of labor, right? So that is the advantage gained by controlled cord traction, and it should be done and recommended when trained skilled birth attendants are available, okay, as a part of active management or third stage of labor. So this is not the best answer to choose, right? Which intervention is recommended to prevent PPH, primarily due to uterine atony? Obviously, the answer will be uterotonic. And which uterotonic? 10 units oxytocin immediately after delivery of the baby. This is preferably within 1 minute. Preferably within 1 minute after delivery of the baby. Okay, and also please remember, active management of third stage of labor starts after delivery of all the babies. I mean, if it is multiple pregnancy, then after all the babies have delivered, then the active management of third stage of labor will start. Keep that in mind, very, very important. And also note and update. Uterotonics for prevention of PPH, and this is from the WHO update which has come recently, somewhere in the end of the year, right? Now, make a note here. The drug of choice, the preferred drug is oxytocin, okay? 10 units is the dose that is recommended. It can be given IM or IV, okay? IV bolus undiluted, absolutely not given. So what is this IV? It can be given in infusion or it can be given diluted slowly also, right? Now, IV is, what the WHO is saying, is preferable if IV access is already there. I'll give you an example. Okay, like example in cesarean section cases. Have you ever wondered how the anesthetist is giving oxytocin for active management of third stage of labor? This we were doing in our OTs. All this while, even before WHO had made this recommendation and given it in recommendations, okay? So have you ever wondered how they are giving? Where are they giving? Because in the labor rooms, you must have seen nurses giving IM in the buttocks. Okay, this you have seen. Where in the OT are they giving? They are giving IV. So what our anesthetist used to do is give 5 units in the IV infusion vac and 5 units slowly, diluted slowly in the IV line directly. So again, there are different ways to do it, but what you should remember is that if IV access is already there, so WHO is saying this has to be diluted. Okay, it has to be diluted and given slowly over 1 to 2 minutes. Okay, now the second drug that they are recommending is carbetocin, right? So oxytocin needs cold chain, right? Now in case cold chain cannot be established, then carbetocin is the drug that is preferable, and heat stable formulation of carbetocin they are recommending. It is also available 100 microgram IM or IV. Okay, so this is one thing. The third drug is misoprostol. So in peripheral centers where even maybe oxytocin cold chain cannot be established, carbetocin not available, and skilled birth attendant, like for example, lay healthcare workers have to be provided with these drugs or administration of these drugs, then misoprostol. So misoprostol 400 or 600 microgram orally. Okay, so these are the 3 drugs which are recommended by WHO. Okay, now also remember that ergometrine, methyl ergometrine, methergin is not recommended. Injectable prostaglandin formulations like carboprost is injectable PGF2 alpha, PGE2, prostaglandin E2. We have a gel form which is used for induction of labor, that is cerviprime gel. There's also an injectable form, that is sulprostone. These are also not recommended. Symptometrine, oxytocin, ergometrine, methyl ergometrine combination not recommended for AMTSL, not recommended for prevention of PPH. Okay, so remember these important things, right? So methergin, we anyways in our labor rooms have never been giving methergin for active management of third stage of labor. I've already told you there is increased risk of retained placenta with that. So we never used in our labor rooms any which ways. Okay, next question. A 28-year-old pregnant woman at 33 weeks gestation. Okay, she presents for routine visit and she is reporting decreased fetal movements. She otherwise has also a history of GDM and her pregnancy has been otherwise uneventful. So the important thing here is not that she has gestational diabetes, but the important thing here is that she is reporting decreased fetal movement. So some surveillance, some form of antepartum fetal surveillance is very, very important right now. Okay, to look at the current condition of the baby. Yes, there are high risk factor like history of GDM is there, but even if history of GDM was not given to you, answer would not have changed. That is why I say that in this question important is decreased fetal movement. So what is the most appropriate initial test? You will not give her contractions and check if the baby is doing well with contractions or not. So this is anyways out. What are we doing in clinical practice? Non-stress test, isn't it? So non-stress test tells us about the acute well-being of the baby. All right, right? 2 accelerations in 20 minutes should be there, and if it is there, we call it as reactive NST. Okay? If 2 accelerations in 20 minutes are not there, then what do? We will continue the test for another 20 minutes. We will do the test for full 40 minutes before labeling it as non-reactive, right? And yes, amniotic fluid index, what about that? Do you want to check the amniotic fluid index? I want to check the amniotic fluid index also. So when you have 4 options and you have to choose between amniotic fluid index versus non-stress test, I want to do non-stress test, because amniotic fluid index will tell me what? It will tell me about the chronic status, right? It will tell me about the chronic status. So if the pregnancy has been complicated, if there is uteroplacental insufficiency, chronically uteroplacental insufficiency has been there, it will lead to oligohydroamnios, or like in the case of gestational diabetes, polyhydroamnios is more likely. So polyhydroamnios also I will be able to see. So yes, amniotic fluid index I want to check and see also. But priority wise I want to do non-stress test. Okay? If we perform non-stress test along with amniotic fluid index assessment, what is that? That is modified biophysical profile, isn't it? That becomes modified biophysical profile. But yes, let's say for example, the non-stress test is also non-reactive. Okay, then we go for biophysical profile. If the non-stress test is non-reactive, then we can go for the full biophysical profile to decide then what intervention to do, right? So for now, the initial test is non-stress test. Next question. A 35-year-old female patient presents to the clinic for evaluation of fertility status. She's been trying to conceive for a year without success. So which of the following is the single best test for assessing her ovarian reserve? So the single best test is anti-Mullerian hormone testing. We do it, we call it serum AMH, and we can do it anytime during the cycle. Anytime during the cycle, that is the advantage. And basically it correlates very closely with the residual follicular pool, because AMH, this hormone, is coming from the smaller preantral and antral follicles, right? So the levels of serum AMH, they reflect how many follicles, the smaller preantral and antral follicles, are remaining in the ovary, reflect the residual follicular pool. And that is why these are what? This is the single best test. Most importantly, it can be done anytime during the cycle. Okay, clear? Fine. Now, what about other? The other tests are also done. Day 3 FSH, day 3 estradiol, serum inhibin levels, they are also done. In fact, antral follicular count, transvaginal sonography, antral follicular count on day 3, that is also done. Okay, right? Now, in clinical practice, estradiol levels alone, they are not very useful. Okay, so in clinical practice, when we do go for day 3 hormone level analysis, we often check the ratio of FSH and estradiol ratio. Okay, FSH also on the higher side, FSH also on the higher side will mean poor ovarian reserve. Okay, FSH on the higher side will mean poor reserve. Okay, and this ratio we generally tend to check. But estradiol levels alone, serum estradiol levels alone, they are not clinically very useful. Okay, so keep this in mind as well. Next question. A 25-year-old female presents with irregular menstrual cycles, acne, excessive hair growth over chin and upper lip, right? So menstrual cycle abnormalities, criteria 1, excessive androgen evidence is there, isn't it? It can be clinical and or biochemical. So this is clinical evidence of excess androgen. So that is there. Ultrasound reveals multiple follicles and bulky ovaries. So now in this context, this ultrasound appearance of multiple follicles and bulky ovaries. So bulky ovaries mean ovarian, what will qualify as bulky? Ovarian volume more than 10 ml. That will qualify as bulky. Okay, multiple follicles, if you look at the current, if new criteria, it is more than 20 follicles in either ovary. Okay, so in this context, what is the diagnosis? Yes, polycystic ovarian syndrome, PCOS. And what are we talking about? The Rotterdam's criteria. Know this name, know this criteria. 2 out of 3 are needed to make the diagnosis. Here they are mentioning all 3, but I have ticked the 2. Irregular cycles, excessive androgen evidence is there. Whether clinical and or biochemical can also be there. Okay, so checking for serum androgen levels is also done. Okay, and ultrasound appearance of polycystic ovaries. This is the 3rd criteria. So 2 out of 3 are needed to make the diagnosis of PCOS, and that is your answer, right? Now ovarian hyperstimulation syndrome, that is a different entity altogether. Okay, ovarian hyperstimulation syndrome, that is a different entity altogether, where the ovaries get enlarged and bulky, containing multiple follicles. Multiple large follicles are there because we are stimulating the ovaries with gonadotropins during IVF cycles. Okay, so this is a different entity altogether. Endometriosis, we all know, is a different clinical profile altogether. And hypothyroidism. Now see, Rotterdam's criteria, please remember, when we make the diagnosis of PCOS, using the Rotterdam's criteria, of course, we also have to rule out other common causes, right? So one should rule out thyroid disorders like hypothyroidism, okay, hyperprolactinemia. Well, both hypo as well as hyperthyroidism can contribute to irregular cycles. So basically rule out thyroid disorders in general. So keep that in mind. So we have to rule out other common causes also before labeling it as PCOS. This is also a very, very important thing clinically. Okay, that we should rule out other common causes also. Don't think hypothyroidism as the answer. Clinically, it is most likely, yes, answer is PCOS in this question. But yes, in clinical practice, one has to rule out other causes as well. Next question. Which sign of pregnancy is denoted by the following image? Direct image based question. You can see that there is a pregnancy inside. That is what this is depicting. And you can see here that this is the region of the isthmus, which is very soft, softening of the isthmus. And during bimanual pelvic examination, the fingers of the 2 hands, they can approximate, right? So this is Hagar's sign. Okay, Hagar's sign is because of softening of the isthmus. Goodell's sign is softening of the cervix, right? The cervix feels as soft as the lips, right? Osiander's sign is pulsations which are felt through the lateral vaginal fornix, right? So here, if you have, look at this, from the lateral vaginal fornix, this is the location of the uterine artery, right? So the uterine artery is dilated in pregnancy. The blood flow through the uterine artery increases during pregnancy. So pulsations can be felt through the lateral vaginal fornix. And Palmer's sign is basically the rhythmic uterine contractions that can be felt on bimanual pelvic examination. Okay, so this is the Palmer's sign. These are the different signs, and image-based question among the signs is possible for in your exams or Hagar's sign only. Okay, so keep that in mind. Next question. 75% of iatrogenic ureteric injuries are due to gynae procedures. Which hysterectomy route has the least risk of ureteric injury? Now they're asking you least risk. Answer is vaginal hysterectomy. Okay, so what happens is, I'll tell you, look at this. Now this is the location here. Can you see? This is the location here where the ureter is crossing over the uterine artery. Okay, now this is the most common location of ureteric injury in gynae surgeries. Okay, now obviously when the uterus is approached abdominally, okay, when you look at this, when the uterus is approached abdominally, right, we will place a clamp here, tubo-ovarian clamp, then we'll have to place a clamp here in the uterine artery, then we have to place a clamp here on the cardinal and the uterosacral ligaments. So we have to free the uterus of its attachments and appendages to take out the uterus. Isn't it, right? So in hysterectomy, when we are doing abdominally, okay, when they say abdominal, it means open, laparotomy, okay. When we are doing laparoscopic, it is still abdominal, but the difference is minimally invasive, isn't it? We are going through the laparoscopic ports. But the principle remains the same, no? That obviously you are going to approach the tubal pedicle, first tubo-ovarian pedicle, then the uterine artery pedicle, and then the ligaments pedicle, the cardinal and the uterosacral ligament pedicle have to be approached, right? So from here, see, this is the first pedicle, then the uterine artery pedicle, then the cardinal, uterosacral complex, and then this whole specimen will be taken out, right? That is the approach. It's just that we'll go minimally away with the laparoscopic ports, and we'll have those ligashore is what we use to ligate these pedicles, you know, when we're going for laparoscopic. The principle remains the same, however, right? So what precaution do we take? We try to stay as close to the uterus. Right? Isn't it? Because the more lateral we go, the more dissection we have to do, and you know, the more lateral we go, chances is that we can, you know, maybe tie this ureter in the clamp, ligate it, you know, injure it like that. Okay, so that is the thing. Now, robotic also, if you look at it, the robotic will be minimally invasive and laparoscopic only, right? Now, what about vaginal? When we go for vaginal hysterectomy, we have to pull, you know, we have to pull this uterus from the vagina. Okay, so the technique of vaginal hysterectomy is such that when we do the dissection, we keep pulling at the cervix, okay, from the vaginal root. When we do that, look at this. The sequence of clamps in vaginal hysterectomy will be different. The sequence of clamps in vaginal hysterectomy is opposite as compared to abdominal hysterectomy, right? So first we will have to, when we are going from have a look. When we are doing vaginal hysterectomy, the sequence of clamps will be reversed, right? We'll first put clamp here because we're approaching from below. First, we'll put clamp on the cardinal uterosacral ligament complex, right? And now this portion here would become free, and then we will pull the specimen from the vagina, right? And then we will clamp the uterine later, right? So when we try to pull it up, what happens is that this ureter is sort of, you know, it stays out of harm's way, because we are pulling the specimen from below. So it has been seen that with vaginal hysterectomy, there is least risk of ureteric injury because of the technique that we use to perform the hysterectomy, right? So that is very, very important to note. Now, as far as laparoscopic versus abdominal is concerned, open, right? Please remember that laparoscopy has got more risk of ureter injury as compared to abdominal because of the ligashore and the electrosurgical principles and the electrosurgical instruments that we are using. Thermal injury to the ureter can also happen when we are trying to, apply the, when we are ligating the pedicles using thermal energy, like ligashore is used during laparoscopic surgeries, right? So thermal injury can happen. So with laparoscopic versus abdominal, it is slightly more in laparoscopic. Next question. Which vaccine is contraindicated in pregnancy? Yes, varicella vaccine is contraindicated in pregnancy. Please remember, all live vaccines, they are definitely contraindicated in pregnancy. So the live influenza, not the inactivated influenza, the live influenza vaccine is contraindicated, MMR is contraindicated, varicella is contraindicated. So remember these important ones, right? Now rabies. If a woman gets bitten by a dog in pregnancy, right? Do you really think that you would avoid the vaccination because rabies is life-threatening if it happens, right? So rabies vaccination is not contraindicated in pregnancy, right? What is Tdap? Tdap is inactivated, right? Tetanus toxoid. Tdap is tetanus toxoid, diphtheria, adult diphtheria, and acellular pertussis. This is also inactivated, and this is also safe in pregnancy, isn't it? So please remember, when we are talking about routine immunization in pregnancy, right, which is offered to all pregnant women, as per the Government of India recommendation, it is TT/TD, 2 doses, tetanus toxoid, and now the Government of India is moving towards, it has recommending TD, right, tetanus and adult diphtheria. What is Tdap? Tdap, many private practitioners are also giving because the woman has to buy this vaccine out of her own pocket. This is not available free of cost in the government centers. Okay, so this is according to ACOG recommendations. Tdap in every pregnancy, irrespective of prior vaccination status, 1 dose, 27 to 36 weeks. This is according to ACOG. Okay, and your inactivated influenza vaccine is also recommended in pregnancies. 1 dose intramuscular given in the flu season, irrespective of whatever gestation she is during the flu season. So inactivated influenza is also we are recommending in private practice. But again, in Sarkari, it will not be possible. These vaccines will not be available free of cost. So remember these important points as well. Next question. A 32-week preemie presents with abdominal pain, vaginal bleeding, blood pressure 150 by 100, tender uterus, fetal heart rate on the lower side. So this is condition antepartum hemorrhage. 2 most important possibilities to consider: placental abruption and placenta previa. Placenta previa has painless, causeless bleeding. Here, risk factor is given to you. Hypertension, it could have been blunt abdominal trauma, also may have been mentioned. And uterus tense, tender, tone increased. All of these go in favor of diagnosis of placental abruption, isn't it? So that is your answer. Okay. In such situation, the next step would be to perform an urgent ultrasound. Okay, first the sonologist is going to do transabdominal ultrasound, and if needed, he may also do a transvaginal sonography, but generally it is transabdominal sonography first and transvaginal if the sonologist wants to see, if specifically see where the placenta is in the lower uterine segment, then. So it depends, all right. So urgent ultrasound needs to be done to rule out previa. Basically, urgent ultrasound is done to find the location of the placenta. Keep that in mind. In placental abruption, placenta will be upper segment. Okay? Fine. So, I have discussed next step also with you. Why is it not uterine rupture? Well, in history, nothing is given which way will make you think uterine rupture. In uterine rupture also, maybe a laboring woman will have uterus rupture. Okay, that is what it is. It means woman in labor, she is getting pains and then the uterus ruptures and then vaginal bleeding happens. But where is the clinical context? Where are the clinical circumstances in which rupture will happen? So, clinical circumstances, rupture uterus will be the diagnosis when clinical circumstances tell or show that it is potentially could be rupture. So, some risk factor must be given to you. Uterus rupture happened. Why? Maybe she was a previous cesarean undergoing vaginal delivery. Right? Maybe she was a grand multiparous woman getting too much of oxytocin. So, some clinical context will have to be set if it is uterine rupture. Now, with uterine rupture, they will tell you more things like, the fetal parts are superficially palpable with uterine rupture. Or they may tell you that there is loss of uterine contour. Right? So, that is why the answer here is not uterine rupture. And the answer is not vasa previa either, because the clinical circumstances are not going in favor of vasa previa. They are going more in favor of placental abruption. Vasa previa is uncommon. It is not a very common condition. Right? So, with vasa previa, history would be like, that a woman is in labor and with sudden rupture of membranes, there is fresh bleeding and there is sudden fetal distress. Sudden severe fetal distress is there because fetal vessels have ruptured. Fetal vessels that were traveling in the membrane, they have ruptured. Right? So, vasa previa is also not the diagnosis in this question. Next question. Identify the device. This device is Lippy's loop. Straightforward question. Alright. So, Lippy's loop is an inert intrauterine device, right? Mirena is the prostaglandin containing intrauterine device. Copper T has copper wire around it. Progestasert is also hormonal. Progestasert is not available in the market anymore. It's mainly Mirena when we're talking about progesterone containing devices. So it's a straightforward image based question. Lippy's loop, it's an inert first generation intrauterine device. Second generation devices are the copper containing devices, and the third generation devices are the hormone containing intrauterine devices, in which we have Mirena and Progestasert, and Mirena is what is in the market available now. What is the dose of misoprostol in the first trimester medical abortion? Or doses of misoprostol, important answer is 800 micrograms. Okay, 400 micrograms is the dose in second trimester abortions, right? So, for misoprostol is PGE1, please remember that also. For medical abortion, the drug of choice, the regimen of choice, let's say the regimen of choice is mifepristone plus misoprostol combination. Okay, meso can be given alone, but mifepristone not recommended alone. Okay, mifepristone 200 milligram orally, that's the same for all trimesters, and meso is the dose that changes. So, in first trimester, dose of meso is 800 microgram, and meso is given 24 to 48 hours after giving mifepristone, right? And for second trimester, it is 400 microgram every 3 hours for a maximum of 5 doses. Okay, generally, Government of India mentions maximum of 5 doses. Okay, other Western guidelines, the WHO is not keeping a cap on the maximum number of doses, but you should remember the Government of India booklet does say maximum of 5 doses. 25 micrograms lower dosage is used for induction of labor. Okay, So remember this, very, very important. And another place where misoprostol is used, active management of third stage of labor, their dose is 400 to 600 microgram. Okay. And we discussed this in the AMTSL question also. Which of the following is not a hyperestrogenic condition? So basically, which of the conditions here is not associated with increased, estrogen levels, basically, or is not a condition which is estrogen dependent, so to say, right? So obviously low BMI, obesity, hyperestrogenic condition, peripheral fat cells. What happens in the peripheral fat cells? Aromatase enzyme. What happens because of that? Androgens get converted to estrogen. Okay? Fine. So, low BMI is not a hyperestrogenic condition. Okay? Now, ovarian cancer. There can be certain ovarian cancers, certain ovarian histology cancers like granulosa cell tumor, which can secrete estrogen. Right? Endometriosis, estrogen dependent condition. Right? The deposits of endometrial glands and stroma outside the uterus. Right? Those endometriotic deposits. Right? These endometriotic deposits are also estrogen dependent. These endometriotic deposits have also got rich aromatase activity. And tamoxifen usage, how is it a hyperestrogenic condition? Yes, tamoxifen usage is basically, what is tamoxifen? Selective estrogen receptor modulator. Okay, so it is not going to cause excess estrogen levels basically, but SERM, this certain estrogen receptors, what does SERM mean? It means that in certain estrogen receptors, they will have agonistic activity, certain estrogen receptors will have antagonistic activity. So tamoxifen has estrogen agonistic action on the endometrium. Right? So it can be associated with endometrial hyperplasia and cancer also. Okay, fine. So out of all these options, low BMI is not a hyperestrogenic condition. In fact, excessive weight loss can also lead to amenorrhea by hypothalamic pituitary axis suppression. Okay, then estrogen deficiency can occur. Okay, next question. A female undergoes methylene blue 3 swab test and the middle swab is stained blue. What is the likely diagnosis? So this methylene blue dye test, it is basically for evaluation of genitourinary fistulas. Okay, now the answer is vesicovaginal fistula. Okay, if you look at the other options, we're going to talk about this 3 swab test briefly here. Okay, now look at this. This is the genital tract. Diagrammatically, I'm showing to you, and this is the bladder in front. Okay, now what we do in the 3 swab test is we fill the bladder, retrograde fill the bladder with methylene blue dye. Retrograde, we fill the bladder with methylene blue dye. Okay, and then we fill the vagina with swabs, 3 swabs. And we ask the woman to walk around, then take out the swabs and check which of the swabs are stained blue or not. Okay, the utility of this methylene blue dye test or methylene blue dye swab test, 3 swab test, is basically in determining whether it is a vesicovaginal fistula or it is a ureterovaginal fistula. This I keep teaching. Right? In the main lectures also I've taught this, in the rapid revision lectures I've also taught this. So vesicovaginal fistula, ureterovaginal fistula. Between these two, it makes the distinction. That is it. Doesn't tell much about anything else. Okay. So what we see here is, let's supposing if it was a, let's say the ureter is here. Okay. If it was a ureterovaginal fistula, we have put the dye in the bladder, not in the ureter. We've put the dye in the bladder, not in the ureter. We filled the bladder. Okay. So, if it is a ureterovaginal fistula, it will not be, none of the fistula, not stained blue. None of the swabs will stain blue, but will be wet with urine. So, it is not a ureterovaginal fistula, out. Okay. Now, uterovaginal fistula and vesico-uterine, uterovaginal fistula, between the uterus and vagina, wrong option only, out. Vesico-uterine fistula, between the bladder and the uterus. Okay, very, very rare first of all. Okay, very, very rare first of all. And what happens with vesico-uterine fistula? Urine comes out from the bladder. Vesico-uterine fistula is very rare. It is associated with menorrhea and amenorrhea. Very, very rare. Okay, right? And what about our answer, vesico-vaginal fistula? See, if there is a vesico-vaginal fistula, the swabs are stained blue. So, uppermost swab could stain blue. The middle swab could also stain blue. Okay, middle swab could also stain blue. Right? So, the answer here is vesico-vaginal fistula. If only the lowermost, if only this lowermost swab stained blue, then I would think urethrovaginal. If only the lowermost swab is stained blue. Right? So, now you get it. The answer here is vesico-vaginal fistula. Next question. Which of the following contraceptive agents are used as first-line agents in heavy menstrual bleeding? First-line agents. What have I taught you? Combined oral contraceptive pills. Easy to use, easy to prescribe, available in the government of supply, free of cost, and also inexpensive option and can be taken orally. Right? They are the drug of choice to begin with in reproductive age group women. Now, progesterone only pills can also be used. They can also be used. Mirena is also a very, very important agent. Remember, Mirena is an important agent for abnormal uterine bleeding. Levonorgestrel containing intrauterine device for abnormal uterine bleeding has been used, isn't it? Right? For heavy menstrual bleeding, it is very, very helpful. Progesterone therapy in all forms has been used. Right? But first line, generally common clinical practice, combined oral contraceptive pills. Copper containing devices, they are not used for heavy menstrual bleeding, right? Contraceptive patches is also not used. They are contraceptive patches used for contraception, but they're not used for treatment of heavy menstrual bleeding, okay? Next question. 26-year-old woman for routine gynae examination, vaginal cytology has been performed and following cells are seen. So, if you look at these cells of vaginal cytology, these are the stratified squamous epithelial cells, right? And predominance of which cells can you see? The red colored cells with a small pycnitic nucleus, right? Abundant cytoplasm staining pink, rich in glycogen cells. We're talking about the cornified cells. We're talking about the superficial cells. These cells predominate under the influence of hormone estrogen. Under the presence of progesterone, we get the intermediate cells. Okay, and the basal and parabasal cells, they predominate when there is no hormone exposure. Okay, 25-year-old female, yellow, green, foul-smelling vaginal discharge, greenish vaginal discharge. Painful urination is also there. Pain during intercourse is also there. Intense itching is also there. So additional symptoms, urinary symptoms are there. So pain during intercourse was also going in favor of intense, vaginitis, intense cervicitis. On per speculum examination, vulva vaginal walls appear inflamed. Okay, now they could have mentioned to you strawberry cervix also or vagina. Right, so intense vaginitis, intense cervicitis must be there. What is the causative agent? Trichomonas vaginalis. So trichomonas can cause cervicitis also. It is obviously, we studied under vaginitis, it typically causes vaginitis, but yes, the cervix can also be inflamed with trichomonas vaginalis. Vaginal walls they are mentioning are appearing inflamed and greenish discharge is there. Right, Candida albicans presents with, candidiasis present with curdy white discharge, right? Gardnerella vaginalis, again grayish white discharge coating the vaginal walls, but bacterial vaginosis, it's a foul smelling discharge coating the vaginal walls, white discharge coating the vaginal walls, thin milky white discharge coating the vaginal walls, but there is no itching with bacterial vaginosis, and there is no vaginal walls inflammation is also not there with bacterial vaginosis. Bacterial vaginosis is not a sexually transmitted infection. It is just alteration in the vaginal microflora. So that is what we see na, Gardnerella vaginalis. Predominance of gram-negative rods instead of the lactobacillus. And Neisseria gonorrhea typically causes cervicitis, yes, typically causes cervicitis and more of purulent discharge. So Neisseria gonorrhea typically causes cervicitis, can cause PID also with ascending infection from the cervix. The infection can ascend upwards, endometritis and salpingitis may occur, and then it can present with PID also. So then again the complaint will become that of pelvic pain, and complaint will become of purulent discharge, right? Like that. So here they are not mentioning anything about the cervix per se. Okay, they are not mentioning anything about the discharge coming out of the cervical os. So on per speculum examination, they are telling you just what? That the vulva and vaginal walls appear inflamed. Okay, so if there is clinical evidence of cervicitis, one may see the purulent discharge from the os, coming out from os, inflamed cervix, maybe cervix that is bleeding on touch, right? Unhealthy looking cervix, some information that they will give you, right? And with if there is evidence of PID, then PID you should have at least, the minimum criteria to call PID. Minimum criteria will be, they mention uterine tenderness on clinical examination, adnexal tenderness, right, or cervical motion tenderness. So some at least bare minimum criteria for PID they should have mentioned if they are wanting to ask you about PID. Now they are not mentioning all of these things, so it does not look like Neisseria gonorrhea. So this is going in favor of Trichomonas vaginalis. Next question. 28-year-old woman presents with endometriosis where abdominal surgical scars. Okay, abdominal scar. So scar site endometriosis. It could be abdominal surgical scar following a cesarean section, abdominal surgical scar following any abdominal surgery for that matter, and even in episiotomy site. Scars. Which theory explains? Direct implantation theory. Right? Sampson's theory is the most commonly accepted theory. Okay, it is the theory of retrograde menses and implantation. Halban's theory is basically the theory of lymphatic and hematogenous dissemination, which explains endometriosis in distant sites. Ivanov's theory is the theory of coelomic metaplasia, right? So, inside the peritoneal cavity, which is also derived from coelomic epithelium, right, there can be metaplastic of coelomic epithelium also, considering the Mullerian ducts or the paramesonephric ducts which gave rise to the uterus are also the invaginations of coelomic epithelium. So, embryologically there is a link, right? So, they said that yes, all the structures which are, derived from coelomic epithelium, their metaplasia could occur. So, that is another theory, which is Ivanov's theory of coelomic metaplasia. Next question. 28-year-old primate, third trimester, complain of dizziness and shortness of breath when lying on her back. She feels better when she shifts to her left side. What is the likely condition? So, what happens? In the third trimester, gravid uterus too big, woman will lie down prolonged, there will be compression of inferior vena cava, compression of inferior vena cava. Because of that, there will be decreased venous return. Because of that, there will be decreased cardiac output and there will be decreased blood pressure. Right? So that is why she is having dizziness. That is why she is having dizziness. That is most important, right? Shortness of breath has got nothing to do with inferior vena cava compression. Okay? So dizziness, yes, of course, has got to do with low blood pressure, right? This is what we call as supine hypotension syndrome. Okay, inferior vena cava compression. Why? Because the uterus is slightly dextro-rotated, tilted toward the right side. So, there is inferior vena cava compression. There is decreased cardiac output, like I told you, not because of increased abdominal pressure, has got nothing to do here, right? And on supine position, lying down on supine position, what will happen because of the decreased cardiac output? The placental perfusion, whatever cardiac output comes, that perfuses the placenta. Now, part of the cardiac output only will perfuse the placenta, right? So, lying on the back is not good for the woman. Lying on the back, with too much lying on the back, will cause decreased placental perfusion, right? Left side, left lateral position is better. Left lateral position is better. Why? Because the cardiac output is better, because the placental perfusion is better. Why is the placental perfusion better? Because obviously the uterine artery blood flow will also be better, right? Cardiac output will perfuse the uterine vessels also. So, that will be better in the left lateral position, not in the back side, not lying down supine. Next question. Which is the most common non-tubal site for an ectopic? So, fallopian tube is the most common site, right? Inside the tube, ampulla is the most common site. After tube, it is ovary. After tube, it is the ovary. It is the second most common site after tubal ectopic. Okay? Cervical, abdominal, cesarean scar ectopics, these are rare ectopics, right? Next question. According to WHO, what hemoglobin range defines moderate anemia? What did I tell you? Anemia, remember, hemoglobin less than 11 gram per deciliter in pregnancy, right? This is pathological anemia. Okay, I told you to remember severe. Severe is less than 7 gram per deciliter, isn't it? So, what would be moderate? Moderate would be 7 to 9.9. Okay, and below 7 is severe, like I told you, and this one here is mild anemia. This is according to WHO. WHO gives 3, mild, moderate, severe. ICMR adds another, very severe, which is hemoglobin less than 4 gram per deciliter. That is only in ICMR classification. Next question. 32-year-old pregnant woman, 32 weeks gestation. She has type 2 diabetes. She is well controlled on metformin. Despite compliance, there is occasional difficulty to maintain stable blood sugar levels. Which fetal complication is most commonly associated with maternal diabetes in pregnancy? So yes, what is your answer? Macrosomia is your answer. Fetal overgrowth. Please remember, this is explained by Pedersen's hypothesis. Pedersen's hypothesis, right? What happens? There is maternal hyperglycemia that leads to fetal hyperglycemia, right? That leads to fetal hyperinsulinemia. In response to the fetal hyperglycemia, there is fetal hyperinsulinemia, and it is fetus's own insulin. Fetal growth is dependent upon insulin and insulin-like growth factor. So this is responsible for fetal overgrowth and macrosomia. This is Pedersen's hypothesis. Very, very important, right? There can be polyhydramnios. Polyhydramnios is more likely, right? Please remember that oligo and fetal growth restriction, they can occur with type 2 diabetes mellitus, but only if there is diabetic vasculopathy. Severe enough to so much of vasculopathy involving maybe the uterine vessels, major vessels of the pelvis, that blood cannot reach the uterus and therefore blood cannot reach the placenta. So if there is pre-existent diabetic vasculopathy, then oligofetal growth restriction could occur in diabetes in pregnancy. Otherwise, polyhydramnios and macrosomia are more likely outcomes, right? So this is only if there is diabetic vasculopathy, okay? And placental abruption can occur because of uterine overdistension, like can happen with macrosomia. So placental abruption will happen because of the consequences of maybe, overdistension of the uterus, but not the most commonly associated with maternal diabetes in pregnancy. Next question. A couple is expecting their first child and is discussing their birth preferences. And is interested in the potential advantages of cesarean delivery. So cesarean is, first of all, remember, and I've always taught you this, that it is indicated. It has to be indicated cesarean section. Which of the following is not typically considered an advantage of cesarean delivery? So when I say indicated cesarean, so cesarean has many advantages, which are very valid also. Like, when you want a quick delivery, right? Because again, we will rapidly take out the baby, rather than going through the process of labor and childbirth, which can be time consuming. So in situations when there is fetal distress and vaginal delivery is not imminent, right? Or when vaginal delivery is not possible, right? Because of fetal or maternal indication, then cesarean is very valid. But apart from that, is there an advantage? Is there any other advantage of cesarean delivery? So, like for example, women sometimes tend to think that, going through the process of labor and childbirth may be a very painful process. So, they go for, or they ask for cesarean on request. So, cesarean on request, you may be seeing it being done, but it is something that is not medically indicated. So, yes, one potential advantage of cesarean delivery is that one can have the convenience and control over birth timing. So this sentence can be interpreted in a variety of ways. Like for example, if one is going for a planned cesarean delivery, elective cesarean delivery, of course, because of some valid medical obstetric indication, right? One will have the opportunity of timing, the scheduling the cesarean. That would be the advantage. Right? So convenience and control over birth timing in that sense is achievable, right? So yes, this would be a potential advantage. So it is an advantage, right? Lower incidence of fetal trauma. Well, yes, lower incidence of fetal trauma in the sense that sometimes, if it's a very big baby or if there's a malpresentation, right? then cesarean section offers the advantage of, it reduce incidence of fetal trauma. So this can be a potential advantage, right? Now, reduce risk of urinary incontinence later on. Reduced incidence. Why? Because again, the perineal injuries and the perineal trauma and the perineal stretch, that doesn't happen when cesarean delivery is done. So reduced risk of urinary incontinence. This is a potential advantage. Potential, I'm saying why? Because this is not an absolute advantage. Please keep that in mind also. All right. It doesn't matter if, somebody who's having, it doesn't matter if somebody says that, I want to go for an elective cesarean section because I want to avoid urinary incontinence in the future. I want to avoid prolapse uterus in the future. That's not a valid indication per se for a cesarean section. So I say, yes, it is a potential advantage. Now, reduce risk of respiratory issues in the newborn. This is not an advantage. Very, very important. This is the most important point that you need to remember, that with cesarean delivery, there is increased risk of transient tachypnea of newborn. Right? What happens with vaginal delivery is that when during the process of vaginal birth, the fetus's lungs, they get squeezed out of the secretions that are there in the lungs, right? With cesarean delivery, that advantage is lost. And that's why there is an increased risk of transient tachypnea of newborns with cesarean delivery, especially if it is an elective cesarean delivery. I mean, especially if a cesarean has been done prior to labor. Especially if it is done prior to labor. And that is also the reason why it is advocated that elective cesarean delivery should be planned after 39 weeks. Unless there is some other reason to do it earlier. Okay. Otherwise, in general, elective cesarean section should be planned after 39 completed weeks, unless there is an obstetric indication to do earlier. Like, for example, if you have, let's say, breech presentation, and we have to, let's say, plan for an elective cesarean section. So we plan it beyond 39 completed weeks. Okay. Right. But if it is a placenta previa, for example, then because of the placenta previa, I want to plan for 37 weeks. Right. So you understand the difference here, that elective cesarean sections, whenever possible, should be planned after 39 completed weeks, until and unless there is some other medical obstetric reason to do earlier. So that is an example. Okay. Next question. During third stage of labor, which of the following interventions is considered a key component of active management? Key component of AMTSL, the most important component, is uterotonic. Immediately after the birth of the baby, preferably within 2 minutes, right? Delayed cord clamping is not the key component. It is, WHO says delay for 1 to 2 minutes, but this is not a key component. Maternal ambulation immediately after delivery, of course, it has got nothing to do with AMTSL. Application of stuck abdominal binder, it has got nothing to do with active management of third stage of labor as well. Okay. A 30-year-old pregnant woman at 40 weeks, 5 days is planned for induction of labor with ARM. Following ARM, gush of clear fluid is noted. Part of umbilical cord is visible. Okay. And pulsating upon vaginal examination. So you see what happened? You did the ARM, look at the sequence of event. ARM done, membranes ruptured, liquor came out. So you were doing the ARM. You see the umbilical cord there at the os. See, and the cervix is only 4 centimeter dilated. So 4 centimeter dilated would be 3-finger dilated roughly. 3-finger dilated, this much you are doing ARM, and after doing the ARM, there is the cord is visible, right? And it is pulsating upon vaginal examination, right? So maybe when we were doing ARM, the ARM is always done digitally guided. Okay, if this question is a lot clinical, actually. And this is also an example that I take up in the main lectures of cord prolapse. Like you were doing an ARM, one finger is inside, right? And 2 fingers are inside, and you were, guiding with the coccus forceps, maybe doing the ARM or doing the ARM digitally with the finger. And the liquor comes out. Just there, you notice the cord there, right? And the cord is pulsating. So what is the most appropriate management for this cord prolapse now? So your hand is inside, let's assume. Okay, so the thing is that the moment you take out your finger was holding basically, right? The cervix is partially dilated, 4 centimeter dilated. Your hand there was actually preventing the entire cord to come out into the vagina and outside. So let it stay there. Lift the presenting part of the cord and then proceed to cesarean section. So lift the presenting part of the cord, okay, and proceed to cesarean section. So basically what you're doing is slightly not pushing the cord. Please do not say that you are going to push the cord. Okay, not push the cord up the presenting part. Not push the cord up the presenting part. That is not what we are doing. We are lifting the presenting part of the cord. Our fingertips are not fiddling with the cord. Our fingertips are pushing the presenting part up slightly so that the cord in that region is not compressed. So this is basically to avoid cord compression. Right? Waiting for spontaneous vaginal deliveries out. With cord prolapse, what is the risk? With cord prolapse, the risk is cord inside the vagina, cord outside the vagina. What is the risk? The umbilical vessels inside undergo vasoconstriction because of the atmospheric temperature, which is lower temperature than what was inside the uterus. So fetus is at risk of sudden hypoxia. So it cannot be waiting for spontaneous delivery, right? Now, direct emergency C-section, like I said, of course, I mean, you can go for a direct emergency C-section also, but it would be better to lift the presenting part of the cord to avoid cord compression. So, I mean, I would say from between option B and C, C is the better choice. If we are going for direct C-section but we can't digitally lift the presenting part off, then we do other things to avoid cord compression, like retrograde filling the bladder, putting the woman in Trendelenburg position, a Sims position, So positional changes can be done to avoid cord compression in case we are not able to lift the presenting part of the cord digitally. So there are various means to avoid cord compression that should be done while we are moving the patient, mobilizing the patient for a cesarean section, right? So that's why I say B, direct cesarean section, I'm not choosing, right? So measures to avoid cord compression should definitely be done alongside mobilizing the patient for cesarean section. Right? Now, deep episiotomy when to? Vaginal delivery with cord prolapse only and only done if it seems that vaginal delivery is just about to happen, right? Otherwise, not at all. Next question. 28-year-old pregnant woman, 32 weeks gestation, BP consistently higher than 150/100, no proteinuria or other symptoms of end organ damage. So this is gestational hypertension. Well, it doesn't matter if it is gestational hypertension, preeclampsia, severe preeclampsia, which type of hypertension, it doesn't matter, right? Which antihypertensive is considered first line for managing this patient's condition? Answer is labetalol. Both nifedipine and labetalol are first-line drugs, but labetalol is the drug of choice. If labetalol is contraindicated, like for example, you read about these contraindications in pharma. Example for like bronchial asthma, for example, labetalol is contraindicated, then nifedipine would be the drug of choice. So both are basically first line, right? Methyl dopahydrolazine are also other oral drugs which are safe in pregnancy, but they're no longer the first line drugs. Also remember that ACE inhibitors, angiotensin receptor blockers, and other beta blockers. Okay, other beta blockers like atenolol, metoprolol, they are contraindicated in pregnancy. Keep that in mind. Also remember that diuretics, they are not preferable for hypertension during pregnancy. I'm especially mentioning during pregnancy because postpartum, after delivery, diuretics can be used. So diuretics are generally not preferable for hypertension during pregnancy, but if there is pulmonary edema, then definitely to treat the pulmonary edema, diuretics will become life-saving, right? So diuretics are not first line, keep that in mind as well. Next question. Identify the following contraceptive device, direct image based question. Femidom is female condom. This is not a female condom. This is a diaphragm. And today's sponge, that is the contraceptive sponge that is pre-coated with non-oxynol 9, that looks different. That is a different image altogether. So this is straightforward question. It's a diaphragm.
A very big hello to all my dear students. So, let us discuss the ophthalmology questions of your pulse test for 24th December. Question number 1. What is the diagnosis for a female patient aged 65 who has a history of chickenpox and presents at the clinic with the following features? All of you, what are you looking at? We are looking at the skin lesions, and this is the distribution of the trigeminal nerve, and we all know that this is nothing but herpes zoster ophthalmicus, isn't it? So I think it was a simple question. Most of the tests are being given to you based on the PYQs so that you all can revise it nicely. So let's answer herpes zoster ophthalmicus. Okay, when you say herpes zoster ophthalmicus, what are the other points that you have to keep in mind? Very important is, let's discuss another question here if you are revising. So what is Hutchinson's rule? With very important exam question, what is Hutchinson's rule? सबको याद है क्या होता है Hutchinson's rule? If the tip of the nose is involved, अगर tip involved है, it is a rule eye will be involved. यानी एक मरीज में जिसमें herpes zoster infection है, if the tip of the nose is involved, then it's a rule that eye will be involved. You remember this? So we are writing here, if tip of nose is involved, then eye will be involved. Why it is so? This is due to involvement of nasociliary nerve. है ना? So this is due to nasociliary nerve. Right guys? So remember this question also. This is very important. एक और चीज बताओ कि dendritic ulcer कौन से condition में मिलता है? Is it herpes simplex or herpes zoster? So याद रखना, remember this, it is herpes simplex keratitis. Herpes zoster में नहीं मिलता है. वहाँ पे क्या मिलते हैं हमें? Pseudodendrites. कैसे पता ये dendrite है कि pseudodendrite? क्या पढ़ा था? Dendrite है कि pseudodendrite? ये कैसे पकड़ते हो? अगर ये dendritic ulcer होता है तो आप सब ने पढ़ा होगा, in a dendritic ulcer what we are getting is knobbed ends, isn't it? So knobbed ends are a sign of dendritic ulcer. But this is mainly a feature of simplex, okay? So this is seen in herpes simplex keratitis. In zoster keratitis क्या मिलता है? हम याद रखेंगे, इसमें अगर आई इन्वॉल्वमेंट होगी तो हमें मिलेंगे pseudodendrites. ठीक है? Okay. Next question. What is the condition in which the cherry red spot as shown in the image below is observed? So many times this question has been asked. So many times it has been asked. Much a repeated question. इसको अच्छे से पढ़ना है. चेरी रेड स्पॉट की डिफरेंशियल डायग्नोसिस आप लोग को टिप पे होनी चाहिए. सो सबको पता है चेरी रेड स्पॉट विच इज व्हाट इज दिस? हर जगह इडीमा है लेकिन सेंटर में इडीमा नहीं है. और ये जो आपको बैकग्राउंड मेनली जो वस्कुलेचर कोरॉइडल दिखता है, इसी को बुलाते हैं चेरी रेड स्पॉट. समझ आया? जब इडीमा होता है, जैसे बर्लिन्स इडीमा है, आर्टीरियल और सेंट्रल रेटिनल आर्टरी ऑक्लूजन है, इन सब केसेस में हो क्या रहा है? इडीमा होगा. आपने मेरे साथ पढ़ा हुआ, यू हैव रेड दिस, दैट हाउ द ब्लड वेसल्स आर आइदर प्रेजेंट एट बिटवीन द ओपी एंड आईएन लेयर, दैट इज आउटर प्लेक्सिफॉर्म, इनर न्यूक्लियर, है ना, या अलोंग द नर्व फाइबर लेयर. तो अगर वो लेयर्स प्रेजेंट ही नहीं है वेरी सेंटर ऑफ फोविया पे, तो वहां इडीमा नहीं हो रहा है. ठीक है? जो वेरी, इसको ऐसे समझो कि रेटिना में जो फोविया में जो वेरी सेंटर ऑफ फोविया, मैक्यूला के स्ट्रक्चर में जो वेरी सेंटर ऑफ फोविया, उसमें सारी 10 लेयर्स नहीं है, देयर आर ओनली 5 लेयर्स. सो एंड इट्स ऑल्सो एन एवास्क्यूलर जोन, वहां पे ब्लड वेसल्स भी नहीं है. दिस इज द रीजन कि वहां पे एडीमा नहीं होता है, और नहीं होता है तो वो बैकग्राउंड आपको कोरोइडल जो वस्कुलेचर है वो चमक रहा है एज चेरी रेड स्पॉट. Got it all of you? Now you got the basic. क्यों मिलता है आपको चेरी रेड स्पॉट? सो चेरी रेड स्पॉट यहाँ पे क्या आंसर हो जाएगा? सेंट्रल रेटिनल आर्टरी occlusion. Right? So this is what you are looking at. This is what is your cherry red spot. और क्या पढ़ा हमने? This cherry red spot is mainly a feature of, let's learn and revise the differential diagnosis. ठीक है? क्या क्या हो गया? पहली चीज है बर्लिन्स इडीमा. ठीक है, बर्लिन्स इडीमा यानी बर्न ट्रॉमा में जो इडीमा हो जाए. इसका दूसरा नाम क्या पढ़ा हुआ है? कोमोशियो रेटिनी. पढ़ा है ना? कोमोशियो रेटिनी. चलिए, दूसरा आप क्या पढ़ते हो बर्लिन्स इडीमा के अलावा? दूसरा होता है सेंट्रल रेटिनल आर्टरी ऑक्लूजन. और तीसरा क्या है? मैंने बोला इसको ऐसे याद कर लो, डिपोजिशंस, है ना? जितने भी आपके स्टोरेज डिसऑर्डर्स हैं, राइट, दे ऑल कम अंडर दिस हेडिंग. टे-सैक्स डिजीज, नीमैन पिक, गाउचर्स, पढ़ा है ना? टे-सैक्स, गैंग्लियोसिडोसिस हो गया, नीमैन पिक. बहुत बार ये डिबेट है कि गाउचर्स में चेरी रेड स्पॉट होता है कि नहीं. प्लीज याद रख लो, होता है. गाउचर्स डिजीज, फिर उसके बाद ऑफ कोर्स GM1 गैंग्लियोसिडोसिस, GM1 gangliosidosis टाइप 2. ठीक है? और क्या मिलता है? सैंडॉफ, सियालोसिस, व्हाटएवर लिस्ट आपको ये पता है, ये सारे फिट हो जाएंगे यहाँ पे. जब मैंने आपको ये बेसिस समझा दिया कि इडीमा हर जगह है और बीचों बीच नहीं है, इसलिए हमें दिख रहा है चेरी रेड स्पॉट. So I think many of you must be thinking, what about in during depositions? All these depositions are in the ganglion cell layer. Again, the ganglion cell layer is not present at the very center of fovea. इसीलिए वहां पे बैकग्राउंड कोरोइड शाइन कर रहा है और आपको दिख रहा है चेरी रेड स्पॉट. राइट? सो प्लीज रिमेंबर, दिस इज इंपॉर्टेंट. Okay, we come to next question. What's the main risk for a 37-year-old man with blurred vision and severe pain in the right eye? Okay, 37-year-old man, blurred vision, severe pain. He revealed recently that he went to the swimming pool while wearing his contact lenses. So सारा कुछ बहुत सिंपल दिखाई दे रही है और रेडियल केराटोन्यूराइटिस भी हो रही है इसको. ये क्या चीज है? रिंग लेजन ऑफ, सबको पता है, अ कॉन्टैक्ट लेंस यूजर using his contact lens, okay, and not wearing any goggles or anything and just going for swimming, he is at a risk of developing acanthamoeba keratitis. ठीक है? So ring like lesion, क्या क्या चीजें इस फेवर में है? ब्लड विजन सबसे इंपॉर्टेंट डायग्नोसिस के फेवर में है. सीवियर पेन, बहुत ज्यादा डिस्प्रोपोर्शनेटली बहुत ज्यादा पेन हो सकता है मरीज को. Went for swimming, wearing his contact lens, very very important point. Ring like lesion, another important point. So बहुत obvious है, was found seen in the image. So what's the main risk? Okay, he's asking the main risk. अच्छा, while wearing his contact lens. So of course main risk is his soft contact lens, nothing other than this. It's a very simple, if I look at the option इन लोग ने जो दिया है ये क्वेश्चन, इसमें ये ऑलमोस्ट ऑब्वियस आंसर है कि ये दिस इज सॉफ्ट कॉन्टैक्ट लेंस. चलो रिवाइज करो इसके अराउंड. फ्रेमिंग ऑफ क्वेश्चन आई एम नॉट वेरी हैप्पी विद, बट एनीवे व्हाट इज द इम्पॉर्टेंट थिंग वी हैव टू अंडरस्टैंड? रिंग लाइक लेजन इन अ कॉन्टैक्ट लेंस वियर हैज टू बी एक्यांथेमोeba केराटिटिस. अब कहाँ हम फंसते हैं वो सोचते हैं. आपसे पूछा जाता है मोस्ट कॉमन इन्फेक्शन आफ्टर कॉन्टैक्ट लेंस यूज. अगर आपसे पूछा गया है मोस्ट कॉमन इन्फेक्शन आफ्टर कॉन्टैक्ट लेंस यूज, क्या बोलोगे? यू शुड आंसर सूडोमोनास. ठीक है? योर आंसर विल बी सूडोमोनास. मोस्ट कॉमन, नेवर एक्यांथेमोeba. एक्यांथेमोeba पर से इज अ रेयर इन्फेक्शन. ठीक है? ओके, अब आ जाओ सेकेंड इंपॉर्टेंट क्वेश्चन. अगर ऐसे सवाल पूछ लिया, सॉफ्ट कॉन्टैक्ट लेंस यूजर इज प्रोन टू विच इन्फेक्शन? अब आप आंसर करते हो एक्यांथेमोeba इज प्रोन टू, अब आप बोलोगे एक्यांथेमोeba केराटिटिस. prone to acanthamoeba keratitis, right? Okay, so और कोई सवाल आता है? acanthamoeba का आपसे कल्चर मीडिया पूछ चुका है, क्या बोलोगे? नॉन न्यूट्रिएंट agar with E. coli. It is non-nutrient agar with E. coli. और क्या सवाल आ चुका है? ड्रग ऑफ चॉइस याद है? ड्रग ऑफ चॉइस क्या होता है कैंथमीबा में? PHMB, दैट इज PHMB क्या है? पॉलीहेक्सामीथिलीन बाइगोनाइड्स. PHMB इज पॉलीहेक्सामीथिलीन बाइगोनाइड्स. ये सारे क्वेश्चंस आते हैं अराउंड acanthamoeba keratitis that we have to be very thorough about. Next question. What is the average degree of hypermetropia in a newborn? पढ़ाया था ना 2.5. क्या पढ़ा था हमने? 2.5 से बहुत सारी चीजें पढ़ी थी. 2.5 is also the depth of anterior chamber. 2.4 to 2.5 पढ़ा था. फिर हमने क्या पढ़ा? 2.5 से और क्या चीजें पढ़ सकते हो? आपने पढ़ा definition of anisotropia. याद है? anisotropia क्या होता है? जब दोनों आंख के पावर का डिफरेंस इज मोर देन 2.5 diopters. So this is when the difference between the two eyes is more than 2.5. Difference between two eyes, the refractive, किसका difference? Difference of refractive power between two eyes is more than 2.5 diopter. Is there any other 2.5 that we are learning? Yes, the question that is asked. So this 2.5, first we learnt about depth, second 2.5 is this, third 2.5 is your that infant is hypermetropic by how much? It is 2.5 to 3 diopters. ठीक है, तो मैंने आपको और भी 2.5 बता दिए. So now what is the answer? You know we are talking about 2.5 diopters. Right? Okay. So once we know this much, चलिए नेक्स्ट क्वेश्चन है आर्ट्स लाइन. सबको पता है आर्ट्स लाइन हर्बर्ट पिट्स कहाँ मिलते हैं? ट्रैकोमा. सो बहुत आसान सवाल है. इसको मेरे स्टाइल में अपने डायग्राम बना लोगे तो कभी भूलोगे नहीं. जस्ट मेक अ डायग्राम एंड लर्न लाइक दिस दैट आर्ट्स लाइन इज यार वे यू मेक अ डायग्राम देन इन ट्रैकोमा दिस इज द कॉर्निया, राइट? ये हो गया आपका प्यूपिल. ओके, राइट. नाउ दिस इज योर palpebral conjunctiva. So what are you seeing? Trachoma में follicles, sago green like follicles on the palpebral conjunctiva and follicles on the upper limbus, जिसको हम क्या बुलाते हैं? Herbert follicles, है ना? उसके बाद क्या होता है? ट्रैकोमा सबको पता है ना क्या है? It's infection by Chlamydia trachomatis. Okay. कौन सा strain of Chlamydia trachomatis? A, B, BA and C. What is the age group? कहाँ होता है ट्रैकोमा? बच्चों में होता है 1 to 9 years of age. बच्चों में होता है इसलिए स्ट्रेन ABC है. ऐसे याद कर लो. ठीक है? So these are all your important exam questions. What is the strain of Chlamydia trachomatis? What is the age group? Where it occurs? Of course we know Fisto classification, वो भी याद रखना. चलो पहले वापस इस पे आते हैं. So इनिशियल इन्फ्लेमेटरी स्टेज में आपको फॉलिकल्स मिल रहे हैं जिसको डिस्क्राइब करते हैं साबूदाने की तरह, सैगो ग्रेन लाइक फॉलिकल्स एंड हर्बर्ट फॉलिकल्स. लेटर व्हाट हैपेंस? स्कारिंग जो होती है वो लीनियर स्कारिंग यहाँ पे भी मिलेगी, स्कारिंग यहाँ भी मिलेगी. इसी लीनियर स्कारिंग को हमने क्या बुलाया? आर्ट्स लाइन. एंड द स्कारिंग हियर दिस इज व्हाट इज कॉल्ड हर्बर्ट पिट्स, है ना? हर्बर्ट पिट्स. ठीक है, इस पे भी सवाल आता है. फिर आपसे एक सवाल पूछता है अबाउट, अभी बताया था ना, फिस्ट ओ स्टेजिंग. स्टेज 1 इज फॉलिकल्स. कितने फॉलिकल्स? 5 या मोर देन 5 फॉलिकल्स. कहाँ पे? अपर की लोअर? अपर पैल्पेब्रल कंजंक्टिवा. सबको याद है? उसके बाद क्या पढ़ा था? आई स्टेज ऑफ इन्फ्लेमेशन. इन्फ्लेमेशन में क्या मिलेगा? इचिंग एंड वाटरिंग, IW. उसके बाद S हो गई स्कारिंग. स्कारिंग में आपने पढ़ा हर्बर्ट पिट्स एंड आर्ट्स लाइन. उसके बाद T आता है ट्राइकियासिस जिसको बोलते हैं मिस डायरेक्शन ऑफ आईलैश. और लास्टली O. O क्या है? कॉर्नियल ओपेसिटी. ठीक है, सो ये सारी बातें आपको रिवाइज करनी है. When you talk about the corneal opacity, this is a very important question here. What is the complication of trachoma? Complication is only one, and that is corneal ulcer leading to corneal opacity. So, the complication of trachoma is only one, that is corneal ulcer leading to corneal opacity. Right, guys? Okay. We come to the next question. इस पे क्या पूछ रहा है आपसे? They are asking you about match the given images to their descriptions. Okay. So, given images to their descriptions. So, here you have these images. Let us try to understand. I will go from this one. Thoda sa images upar niche. Number 4 images, this one. So, this what I can see is a posterior subcapsular cataract. So, I will say 4. This is posterior subcapsular cataract. We all know that this is your snowflake cataract. 3 is D, isn't it? So, 3D and 4A. What about, okay, C and D both are the same. Then we come to Morgagnian, we know it is 2C. So, answer is option C, right? And this is your, I think the image is not very clear, but this they are trying to show you the sunflower cataract. Okay? Yeah, and you have to know all these topics that you matching are very, very important, and many questions are asked from this. Posterior subcapsular cataract पे क्या सवाल आया हुआ है? चलिए समझते हैं. Which lenticular opacity diminishes the vision most? कौन सा cataract है जिसमें सबसे ज़्यादा vision कम होती है? So, it is maximum diminution of vision occurs in posterior subcapsular cataract. One question of snowflake cataract, जिसको हम snowstorm भी बुलाते हैं, is a diabetic cataract, right? It is seen metabolic cataract. It's also called presenile because the patient can develop it before 50 years of age. Now, this presenile or diabetic cataract or a snowflake snowstorm cataract occurs due to another question. You will answer sorbitol accumulation in the lens, right? Sorbitol is very hyperosmotic. वो पानी absorb करेगा and that will cause hydration of lens leading to cataract. और कुछ सवाल? Morgagnian का most common complication पूछता है. Most common complication of Morgagnian. ये सवाल आता है. Complication of Morgagnian. क्या बोलोगे? It is phacolytic glaucoma. It is phacolytic glaucoma. Okay. Right. Sunflower cataract कहाँ मिलता है? ये भी पूछेगा. क्या बोलोगे? Calcosis, which is copper in eye. Right. और क्या पढ़ते हो calcosis में? भूलना मत. KF ring पे बहुत बार question आता है, which is copper deposition. कहाँ पे? Descemet's membrane. Right. Yeah. So calcosis सबको clear है ना? Is copper in the eye. Okay. So ये हो गया आपका different questions on these topics. Next सवाल पे आते हैं. Which is the most common cause of preventable childhood blindness? Obvious है? Vitamin A deficiency, right? और vitamin A deficiency और xerophthalmia के around याद रखिएगा, रिवाइज कर लेना, अच्छे से पढ़ाई कर लेना, WHO grading, ठीक है? So, आपसे एक सवाल आता है कि which is the earliest sign of xerophthalmia या earliest feature किसको बोलोगे? निक्टेलोपिया. निक्टेलोपिया क्या है? नाइट ब्लाइंडनेस. फिर चलो मेरे साथ ऐसे ही वर्बली फटाफट रिवाइज करो. XN के बाद क्या होता है? XN इज xerophthalmic. निक्टेलोपिया हो गया. फिर X1AB क्या होता है? AB A इज कंजंक्टाइवल जीरोसिस और यानी ड्राइंग ऑफ कंजंक्टाइवा. B फॉर B बिटॉट स्पॉट, राइट. चलो दूसरा क्या होता है? X2 ये क्या हो गया? कॉर्निया का जीरोसिस. चलो उसके बाद क्या होता है? X3 इसको भी AB में डिवाइड करते हैं. केराटोमलेशिया ऑफ लेस देन 1/3 ऑफ कॉर्निया एंड ये हो गया मोर देन 1/3. क्या होता है केराटोमलेशिया? मेल्टिंग ऑफ कॉर्निया, लिक्विफैक्टिव नेक्रोसिस. उसके बाद आता है XS, XF. S is scarring and xerophthalmic fundus. क्या होता है xerophthalmic fundus? Which is white spotted fundus. Right guys? तो ये हो गया आपका Grading by, this is your WHO grading of xerophthalmia, very important. फिर आपसे सवाल ट्रीटमेंट पे भी आता है, भूलना नहीं है. अगर मोर देन 1 ईयर ऑफ एज है बच्चे की या पेशेंट की, तो 1 लाख इंटरनेशनल यूनिट ऑफ इंजेक्टेबल विटामिन ए which is given on 01/14. ये नहीं भूलिएगा, 14th day. So I'll give 1 injection today, 1 tomorrow and 1 after 2 weeks. And if your patient is less than 1 year, we half the dose. And if your patient is taking oral, every time you have to double the dose of oral compared to what you're giving through injections. ठीक है? Yeah. So these are some important points आपको याद रखने हैं. Next question पे आते हैं. Please identify the medical condition depicted in the provided image. अगर हम ध्यान से देखें, अच्छा इसमें हमारा ऑप्शन एंट्रोपियन भी है, ट्राइकियासिस भी है, वहाँ पे कंफ्यूजन हो सकता है कि हमें क्या मार्क करना है. बट जब मैं इस लिड मार्जिन को ध्यान से देखो, इफ यू लुक एट दिस, आई कैन सी दैट द होल ऑफ द एंटीरियर बॉर्डर इज टर्निंग इनवर्ड्स. सो आई वुड प्रेफर टू कॉल इट एंट्रोपियन. And any trichiasis या misdirection which is happening due to entropion, ये जो eyelash अंदर चली गई, क्या बुलाते हैं इसको? Pseudotrichiasis. भूलना नहीं, ठीक है? This is pseudotrichiasis. So what is entropion? Inward turning of lid margin. Next question. 62-year-old women है, फैमिली हिस्ट्री ऑफ ग्लोकोमा है, प्रेजेंटिंग विद माइल्ड विजुअल डिस्टर्बेंस, कुछ खास नहीं, 24, लेकिन इंट्राओकुलर प्रेशर है, हाई है. कितना नॉर्मल होता है? 10 to 21. अभी कितना है? इट इज 24. On dilated fundus examination, the following findings are seen. The cup disc ratio is 0.5, okay. Splinter hemorrhage and wedge-shaped retinal fiber defects, which are the early changes that you see in early glaucoma. Later on, cupping बढ़ेगी. I can see the visual field defects, which is not mentioned here. So, what stage of glaucoma I am going to prefer to answer? It's a early glaucomatous change. The amount of cupping, retinal field nerve fiber layer defects, all indicate early glaucomatous change. Right? Okay. We next talk, should I discuss 1 or 2 questions around glaucoma here? So, we should know about what is the normal intraocular pressure. Normal is all your 10 to 21 millimeters of mercury. फिर आपसे ये भी पूछता है कि नॉर्मल डायूर्नल वेरिएशन दिन भर में कितना वेरी करता है, तो आप क्या बोलोगे? अप टू 5 इज नॉर्मल. अप टू 5 mm of mercury is normal, right? और कब बढ़ेगा, कब घटेगा? M for M. It is more in mornings. M for M, it is more in the mornings. बताइए, इंट्राओकुलर प्रेशर जब भी आप मेजर करो, अपना भी मेजर करोगे, it is more in the mornings. Why? Because steroid levels in our body are more in the morning hours. Okay guys? चलो, ठीक है? Okay. And what is the treatment of choice or drug of choice of angle closure or primary open angle glaucoma? ये तो open angle की यहाँ भी समय तो normal जो समझ आ रहा है, कहीं एंगल के ऊपर कमेंट नहीं किया गया है, बट द होल हिस्ट्री लुक्स लाइक मोर टुवर्ड्स ओपन एंगल. एनीवे, सो ड्रग ऑफ चॉइस फॉर प्राइमरी ओपन एंगल ग्लाकोमा, और अगर आपसे एंगल क्लोजर भी ग्लाकोमा पूछे तो भी आपको फर्स्ट चॉइस क्या देना है? लेटानोप्रोस्ट. ठीक है. एंगल ओपन कैसे करते हो? पाइलोकार्पिन बाय कंस्ट्रिक्टिंग द प्यूपिल, वो एक अलग बात हो गई. बट अभी आपको पता नहीं होता कि आप, अगर आपको जस्ट ऐसे क्वेश्चन आ जाए, फर्स्ट लाइन ऑफ ट्रीटमेंट ऑफ ओनली दिस इज द सेंटेंस, तो हमारा आंसर होगा प्रोस्टाग्लैंडिन एनालॉग्स. राइट? ओके, चलिए नेक्स्ट वी टॉक अबाउट, नेक्स्ट सवाल क्या है? अ 28-year-old, लास्ट पॉइंट मेरा समझ आया मैंने क्या बोला? ओपन एंगल में तो फर्स्ट लाइन प्रोस्टाग्लैंडिन है, एंगल क्लोजर में भी पहले वही आंसर करते हैं. वाई? वो समझा रही थी. नॉर्मली क्वेश्चन में अगर नहीं समझाया गया है कि कौन सा स्टेज ऑफ एंगल क्लोजर है, तो पहले आपको यही आंसर करना है. सपोज सवाल ऐसे पूछ लिया गया, व्हाट इज द ड्रग ऑफ चॉइस फॉर ओपनिंग द एंगल? एंगल विल ओनली ओपन व्हेन देयर इज कंस्ट्रिक्शन ऑफ प्यूपिल, तब हम आंसर करेंगे पाइलोकार्पी. अगर सवाल आ गया, व्हाट इज द डेफिनेटिव ट्रीटमेंट ऑफ एंगल क्लोजर, अब आप आंसर करोगे पेरिफेरल आयरोडोटमी बाय एनडी यार्ड. ठीक है? या तो आप मेरे वो जो ग्लाकोमा वाला चैप्टर अच्छे से रिवाइज कर लो। ओके, इस पे आते हैं। 28-year-old पेशेंट प्रेजेंट इन पेनलेस रेडनेस है उसको ऑफ द आई। The ophthalmologist performed a diagnostic test with 2.5% phenylephrine and no change was noticed, मतलब no blanching है ना। phenylephrine टेस्ट डिस्क्राइब हो रहा है यहाँ पे, इस पे रिसेंटली क्वेश्चंस आए हैं, आपको ध्यान देना है। हम ये करते क्यों है टेस्ट, पहले मैं बैकग्राउंड बता दूं। चलो पहले क्वेश्चन पढ़ो। एंड नो चेंज वाज नोटिस विद 2.5%, 10% phenylephrine is used and there should be blanching, जो इस क्लिनिकल स्लाइड में आई डोंट एग्री, इसमें ब्लांचिंग नहीं दिखाई गई है, बट इट शुड हैव बीन अ ब्लांच्ड एरिया। एनीवे, व्हाट इज द मोस्ट लाइकली डायग्नोसिस? आपको समझना है कि मेन कंफ्यूजन डायग्नोसिस का क्या होता है। होता यह है कि आपके पास एक पेशेंट आता है और उसको इस तरह से एक एलिवेटेड एरिया दिख रहा है, करेक्ट, विद सम कंजेशन। अब इसमें आपके ऑप्शंस हो सकते हैं, या तो ये पेशेंट फ्लैक्टेनुलर कंजंक्टिवाइटिस का है, ठीक, दीज आर द 3 थिंग्स यू हैव टू एक्चुअली एक्सक्लूड, या ये नोड्यूलर, बस एक ये नोड्यूलर एपिस्क्लेराइटिस है, ठीक, इन दोनों में कोई खास पेन नहीं होता, ठीक है, बाकी चीजें मिल सकती हैं, रेडनेस, डिस्कम्फर्ट एंड सो ऑन। और अगर वो स्क्लेराइटिस, नोड्यूलर स्क्लेराइटिस है, तो पेन और टेंडरनेस भी मिलेगी, करेक्ट ऑल ऑफ यू। अब सपोज आपके पास ये ओवरलैपिंग सिम्टम्स हैं, आपको डिफरेंशिएट करना है, डायग्नोज करना है। आपने 2.5% पहले फिनाइलेफ्रीन डाला, अगर ब्लांचिंग हो गई, ब्लांचेस बाय 2.5% फिनाइलेफ्रीन, इसका मतलब ये फ्लैक्टेनुलर कंजंक्टिवाइटिस है। ओके, why? Because it is mainly the superficial vessels which are congested in this condition and they gets blanched by the 2.5% concentration of phenylephrine. अब दूसरा है नोड्यूलर एपिस्क्लेराइटिस, दैट मीन्स इफ इट इज नॉट ब्लांच्ड, ब्लांच हो गया फ्लैक्टेनुलर, नॉट ब्लांच, अब उसको 10% पे ले जाओ कंसंट्रेशन और 10% फिनाइलेफ्रीन से ब्लांचिंग हो जाएगी, तो ये नोड्यूलर है। लेकिन उससे भी नो ब्लांचिंग, तब ये स्क्लेराइटिस है। सो नो ब्लांचिंग मीन्स दिस इज अ स्क्लेराइटिस। इज दैट क्लियर ऑल ऑफ यू? क्यों? बिकॉज अब बहुत डीपर वेसल्स कंजेस्टेड होते हैं स्क्लेराइटिस में, जो कि आप 10% से भी ब्लांच नहीं हो सकते। चलिए नेक्स्ट क्वेश्चन पे आते हैं। A 30-year-old patient with HIV presents with vision loss and floaters. On examination, CD4 count बहुत कम है, fundoscopic revealing area of necrosis. What is? अब ये एक टिपिकल फीचर है जहाँ पे नेक्रोसिस है, हैमरेज है, और इसी को आप क्या बुलाते हो, आपको पता होना चाहिए। दिस इज डायग्नोस्टिक सॉस एंड चीज रेटिनोपैथी, एंड सॉस एंड चीज रेटिनोपैथी is a feature of, we all know, CMV retinitis. So here what is the answer? CMV retinitis. Guys, ठीक है? Another question, एक और इसके related discuss कर लेते हैं। अब वो है most common ocular feature of HIV. आप बोलोगे माइक्रोएंजियोपैथी, स्मॉल वेसल की पैथोलॉजी। कैसे प्रेजेंट करेगा? इसमें मिलेंगे हमें कॉटन वूल स्पॉट्स, जो कि कुछ नहीं है, सॉफ्ट एक्सुडेट्स होते हैं। इसमें मिलेंगे माइक्रो एन्यूरिज्म्स, राइट, और क्या मिलेगा? एंड ऑफ कोर्स वी गेट माइक्रो एन्यूरिज्म्स एंड हैमरेजेस। प्लीज करेक्ट है, इट इज हैमरेजेस, राइट। और अगर तीनों दिया है तो आप मेनली आप आंसर क्या करोगे? इट इज कॉटन वूल स्पॉट। जब भी मल्टीपल कॉटन वूल स्पॉट ऑन द अराउंड द डिस्क और मल्टीपल कॉटन वूल स्पॉट ऑल ओवर द रेटिना, दोनों में अंतर है। अगर अराउंड द डिस्क होता है, जनरली ये आपसे सवाल नहीं आता, फिर भी बता देती हूँ, मेरे मुंह से निकल गया है तो, दैट इज पुश्चर्स रेटिनोपैथी। बट मेनली मेनी कॉटन वूल स्पॉट्स आर सीन इन HIV रेटिनोपैथी। क्या कॉटन वूल स्पॉट इंडिकेट कर रहा है? टू मच ऑफ हाइपोक्सिया, ठीक है। नेक्स्ट क्वेश्चन, 70-year-old man with extensive sun exposure has a yellowish triangular patch, and it's funny because ये animated picture डाल दी है, तो that's okay, but I think it's a very good hint and you can make it out. So a 70-year-old man with extensive sun exposure has a yellowish triangular patch on the nasal conjunctiva. The lesion does not extend to the cornea. If it had extended, it would have been more towards pterygium. सबको पता है. What is the diagnosis? We all know we are talking about pingicula. So pingicula के बारे में ध्यान रखना, pingicula fatty जैसा लगता है but उसमें fat नहीं होता. Again both, दूसरी important point याद रख लो, both pingicula and pterygium pathology एक ही है जो आपको याद करनी है, वो है elastotic degeneration of conjunctiva. ठीक है ना. और पिंगिक्यूला के लिए भी कुछ करते नहीं है. अगर कभी इन्फ्लेम हो गया, पिंगिकुलाइटिस हो गई, तब आप उसमें शायद कुछ माइल्ड स्टीरॉइड्स या एंटी इन्फ्लेमेटरी देते हो, और नहीं तो वो पड़ा हुआ है, इनॉक्यूअस है, आपको नहीं डिस्टर्ब कर रहा है, उसको रिसेक्ट करने की भी जरूरत नहीं पड़ती. राइट. सो दिस इज पिंगिक्यूला. Two important things that you have to know: both pingicula same and pterygium have the same pathology, and both are more common on nasal side. Okay, nasal side. So two important points which applies to both pingicula and also pterygium. आपको पता है ना, pterygium is also a very important topic. Please do revise it. Right. Next question is, 7-year-old child has been brought to clinic by her parents due to concern about her right eyes appearing misaligned. So कुछ squint है. On examination, her squint remains constant in all directions of gaze. कौन सा squint होता है? And no diplopia, not report any diplopia, no limitation of movement. So यही आपने comparison या पढ़ा हुआ है. I mean to say differences between concomitant and inconcomitant. Inconcomitant में mainly हम talk करते हैं about paralytic squint. तो यहाँ पे ये कौन सा squint हुआ? Concomitant. ठीक है? Equal in all directions of gaze. No limitations, eye movements are normal, diplopia नहीं है. We are talking about concomitant squint. अब inconcomitant is just the opposite. Paralytic is a type of inconcomitant. Pseudostrabismus means there is no misalignment, बस देखने में लग रहा है कि आँख टेढ़ी है, होती नहीं है. That is called pseudostrabismus. So what's the best option? Concomitant squint. Right? Next question. A 35-year-old man is presenting with a progress, painless swelling in the superolateral part of his left orbit, okay, left side. Examination is revealing, so any growth on the superolateral, you immediately start thinking about lacrimal gland. And this is the reason the dystopia, that is the proptosis, which is a non-axial proptosis, is downwards and inward displacement. And CT is revealing a well circumscribed, smooth and encapsulated mass. And this is the excisional biopsy. So what is the answer? We all know pleomorphic adenoma. And remember, this is also the most common lacrimal gland tumor. What about adenoid cystic? Adenoid cystic is the most common malignancy. Okay, so this is next question should know. Most common is, one I taught you about most common is this one. Second question I'm saying most common malignant, adenoid cystic. Another question, most dangerous, again it is adenoid cystic. Most dangerous lacrimal gland tumor, again we answer adenoid cystic. Right? So that was it. I hope you enjoyed the discussion. Keep working hard, keep getting better than yesterday, right? Be strict to yourself. Self-discipline is self-love, right? All the best. Stay blessed and keep smiling.
Okay, dear friends, we'll see quickly the answers for the pulse test FMGE. The first question, postmenopausal woman slipped and fell down on an outstretched hand in the washroom. X-ray of her distal forearm is given below. What is diagnosed the following condition? You look at the X-ray. I am able to see a fracture line here in the distal radius and it's purely extraarticular. So the right answer should be Colles fracture. Right answer should be Colles. Okay, right? Because in the lateral view, it has a dorsal tilt and dorsal displacement. Okay, so it is Colles. Instead of dorsal, if it is ventral, on palmar side, ventral, then it is Smith. So it is not a Smith fracture. It is a distal radial fracture which is extra-articular and has a dorsal displacement. So the right answer is Colles. Avascular necrosis of the femur head is due to which of the following artery? They are asking, it's a more anatomy question. What is the main blood supply of head of the femur? That's the question. Okay, even though many arteries, 2 or 3 arteries supply, main blood supply of femoral head is from medial circumflex femoral artery. Okay, almost 60-65%. Rest is by lateral circumflex femoral artery, and one is called artery of ligamentum teres. It's mostly an anatomy question. A 30-year-old female presents with complaints of gradually progressive swelling around her wrist for 3 months. Given below is the image of the X-ray film. What's the most likely diagnosis? I am able to see soap bubble appearance in the distal radius, which is involving the epiphysis. So this should be a case of giant cell tumor, and the other name for giant cell tumor is osteoclastoma. Soap bubble appearance, okay, multiple trabeculated things. A young patient presented to the emergency department with pain and swelling of the right knee. A plain radiograph is shown below. What's the best treatment for this condition? See, X-ray shows a patellar fracture, and the patellar fracture is displaced. You see the gap. This is the proximal pole, this is the distal pole. Okay, the gap is big. So this is a displaced patellar fracture. Best treatment for displaced patellar fracture is tension band wiring with K wires. Tension band wiring with K wires. You can't do tension band wiring with cancellous screw. This is a wrong choice. Cylinder cast is for undisplaced fracture patella. Patellectomy is for comminuted fracture patella. So the right answer for a displaced fracture patella is tension band wiring with K wire. All of the following is seen in terrible triad of elbow except terrible triad is otherwise called Hotchkiss triad, which comprises of posterior dislocation elbow, radial head fracture, coronoid fracture. Okay, so which is not a component is olecranon. Fracture olecranon is the wrong choice. All the 3 are components. Terrible triad of elbow is otherwise called Hotchkiss triad, which is a combination of posterior dislocation elbow plus coronoid fracture plus radial head fracture. A 42-year-old woman laborer presented with visible soft tissue and fluctuating swelling in front of the knee. Over the patella, this over the patella means pre-patellar, and discomfort and difficulty with knee move. So the MRI finding is given below. You're able to see a bursitis here in front of the patella. So this is called pre-patellar bursitis. Pre-patellar bursitis is called housemaid's knee. It's called housemaid's knee. Okay? Yes. A 9-year-old boy fell on his outstretched hand and was presented with pain, swelling and restricted movement of the elbow along with a S-shaped deformity. An X-ray was performed. What is the most common type of fracture diagnosis? So this is obviously, this is called fishtail sign, and this is obviously a case of supracondylar fracture. He is asking which is the most common type. Extension type is the most common. In extension, 80% is medial, posteromedial type. Extension type, which is posteromedial, is 80%. So this should be the right answer. Posterolateral is only 20%. Okay. So posterior is the most common type. Extension type. In extension type, it should be posteromedial. A 50-year-old male presents with history of recurring pain, fever, and discharging sinus in the right leg for several months. He reports being treated for osteomyelitis during childhood. Which of the following investigation would be most useful in visualizing the extent of soft tissue? The extent of soft tissue, without doubt, it should be MRI. So the answer is magnetic resonance imaging. A 20-year-old patient presents with painful swelling in the index finger around the proximal phalanx. X-ray was done and it is shown below. I am able to see here, when I am able to see an osteolytic lesion with a pathological fracture. So this should be a case of enchondroma. This should be a case of enchondroma. Common sites are phalanges. Most common site is around ring finger and little finger, but it can affect any phalanx. What is the location at which the radial nerve is getting injured in a Saturday night palsy? Saturday night palsy, we had discussed this several times. Crutch palsy, Saturday night palsy, everything is in the arm. So it should be in the spiral groove. It should be in the arm. Okay, that completes the question discussion, the answers for the pulse test for FMGE. Thank you so much, dear friends.